Hello and welcome. Do you want to successfully complete the D027 OA exam? Then you are in the right place. Our website has free questions and answers for the D027 OA exam. We know OA exams are tough, so our guides and practice questions are all free. With over 100 plus success stories, we have proven our videos will help you pass your exam on the first attempt. In this video, we will cover questions from neurological conditions, gastrointestinal pathology, cardiovascular care, endocrine disorders, infectious diseases. So, let's get started.
Question 1. A 32-year-old patient presents with chronic foul, bulky diarrhea, unintentional weight loss, and chronic iron deficiency anemia. A duodenal biopsy reveals villous atrophy of the proximal small intestine, and serology is positive for IgA tissue transglutaminase. Which dietary teaching is the most important long-term intervention for this patient? Your options are A. Limit dairy products and trial a lactase enzyme supplement before meals. B. Increase intake of red meat and shellfish to correct iron stores quickly. C. Eliminate barley, rye, oats and wheat permanently from the diet. D. Reduce simple carbohydrates and saturated fats to control symptoms. Which one is it? Pause the video if you need more time. The correct answer is C. Eliminate barley, rye, oats and wheat permanently from the diet. C is correct because celiac disease is a permanent gluten-driven autoimmune injury to the small bowel mucosa, and the only effective long-term treatment is strict lifelong avoidance of barley, rye, oats, and wheat. Removing the antigen lets the villi heal and corrects the malabsorption that drives the anemia and weight loss. A is wrong because lactose restriction may help temporarily because villous atrophy causes secondary lactase deficiency, but it does not stop the underlying gluten-mediated damage. The diarrhea will persist as long as gluten remains in the diet. B is wrong because iron-rich food alone cannot correct anemia caused by an inflamed, blunted absorptive surface. Without removing gluten, the malabsorption continues and oral iron has limited effect. D is wrong because reducing simple carbohydrates and saturated fats addresses metabolic disease, not autoimmune enteropathy. The trigger in celiac is a specific protein, not macronutrient balance. Celiac disease is a permanent autoimmune condition where gluten triggers the immune system to attack the small intestine. Understanding the mechanism helps explain why it looks the way it does on exams and in clinical practice. When gluten enters the small bowel, the enzyme tissue transglutaminase modifies it, triggering T-cell attack on the intestinal lining. This flattens the villi, the tiny absorptive fingers of the gut, causing malabsorption of iron, calcium, folate, and fat-soluble vitamins. It is critical to separate celiac from its lookalikes. Wheat allergy is an IgE-mediated immediate reaction. Non-celiac gluten sensitivity has symptoms but no antibodies and no intestinal damage. Only celiac causes true villous atrophy through an autoimmune mechanism. The most reliable first test is IgA tissue transglutaminase paired with a total IgA level, because selective IgA deficiency affects about 2% of celiac patients and can produce a false negative. A duodenal biopsy then confirms the diagnosis, and a strict lifelong gluten-free diet is the only effective treatment. Question 2. Colonoscopy performed on a 28-year-old patient with intermittent right lower quadrant pain, weight loss, and chronic non-bloody diarrhea reveals patchy areas of inflammation separated by normal appearing mucosa in the terminal ileum and ascending colon. Biopsy shows transmural inflammation with a cobblestone appearance. Which condition do these findings most strongly support? Your options are A. Crohn's disease, B. Ulcerative colitis, C. Celiac disease, D. Diverticulitis. Take a second. Which answer would you pick? The correct answer is A. Crohn's disease. A is correct because skip lesions, transmural inflammation, terminal ileum involvement, and the cobblestone biopsy appearance are the defining picture of Crohn's disease. The disease can occur anywhere from mouth to anus, but classically settles in the small intestine. B is wrong because ulcerative colitis produces continuous inflammation that begins at the rectum and is limited to the mucosa of the large intestine. It does not cause skip lesions or involve the terminal ileum. C is wrong because celiac disease damages the duodenum and proximal jejunum through autoimmune injury triggered by gluten. It does not produce cobblestoning or transmural inflammation in the colon. D is wrong because diverticulitis is inflammation of outpouchings in the colonic wall, usually in the sigmoid, presenting with localized left lower quadrant pain. It does not produce skip lesions or cobblestone biopsies. Crohn's disease is a chronic inflammatory bowel condition with some very specific features that set it apart from other causes of chronic diarrhea and abdominal pain. Understanding these features deeply will help you recognize it instantly on an exam. Crohn can strike anywhere from mouth to anus, but favors the terminal ileum and right colon. Critically, inflammation penetrates all layers of the bowel wall, transmural, and alternates with patches of normal mucosa, creating the classic skip lesion pattern. The contrast with ulcerative colitis is essential. UC produces continuous mucosal-only inflammation beginning at the rectum, associated with Pan-ECA antibodies. Crohn produces patchy, full-thickness disease associated with the anti-Saccharomyces cerevisiae antibody, or ASCA. Because inflammation reaches through every bowel layer, Crohn produces complications that ulcerative colitis almost never causes. Strictures, fistulas, abscesses, and perianal disease are the direct consequence of transmural injury. Thus, and seeing any of these on an exam stem should immediately raise Crohn to the top of your list. When a question describes patchy inflammation with normal tissue between affected segments, full thickness involvement, or a perianal fistula, the answer is almost always Crohn. Pair that picture with a positive Oscar and you can answer with confidence. Question 3. A patient is hospitalized with bloody diarrhea, urgency without successful evacuation, and weight loss. Colonoscopy reveals continuous inflammation extending from the rectum into the descending colon with no skip areas. Antibody testing returns positive for perinuclear anti-neutrophil cytoplasmic antibodies. Which diagnosis fits this clinical picture? Your options are A. Crohn's disease, B. Celiac disease, C. Diverticulitis, D. Ulcerative colitis. Before I reveal it, which one do you think is right? The correct answer is D. Ulcerative colitis. D is correct because continuous mucosal inflammation that begins at the rectum and extends proximally, paired with bloody diarrhea, tenesmus, and a positive Pankser antibody, is the textbook profile of ulcerative colitis. The disease stays in the large intestine and does not skip. A is wrong because Crohn's disease produces patchy skip lesions, transmural injury, and a positive ASCA antibody rather than Pankser. Bleeding is less prominent than in ulcerative colitis. B is wrong because celiac disease affects the small intestine, particularly the duodenum, and is driven by gluten exposure. It does not cause continuous large bowel inflammation or Pankser positivity. C is wrong because diverticulitis is an acute infection of colonic outpouchings, presenting with focal pain, fever, and leukocytosis rather than chronic continuous mucosal inflammation visible on colonoscopy. Ulcerative colitis is a chronic inflammatory bowel disease defined by 3 hallmarks: continuous inflammation, strict colonic location, and mucosal-only depth. Understanding these features is what separates it from every other inflammatory bowel condition. The inflammation always begins at the rectum and extends proximally without skip areas. It never penetrates the full thickness of the bowel wall, which is why strictures, fistulas, and perianal disease, hallmarks of Crohn, are uncommon here. Colonoscopy and biopsy together remain the gold standard for diagnosis. The perinuclear anti-neutrophil cytoplasmic antibody is a useful adjunct favoring ulcerative colitis, while a positive anti-Saccharomyces cerevisiae antibody points toward Crohn. The immune system mounts an exaggerated response to gut microbiota, stripping away the mucosal lining. Because deep layers are spared, the dominant symptoms are bloody diarrhea with mucus, urgency, and tenesmus rather than the obstructive or fistulizing complications seen in Crohn. When a stem describes inflammation beginning at the rectum, extending continuously, with bloody diarrhea and crypt abscesses on biopsy, ulcerative colitis fits at every diagnostic checkpoint. Long-standing disease also warrants earlier colorectal cancer surveillance starting at 8 to 10 years from diagnosis. Question 4. A patient with newly diagnosed mild Crohn disease has flares characterized by cramping, low-grade fever, and 3 to 4 loose stools daily. The provider plans to begin pharmacologic therapy following stepwise treatment guidelines. Which medication is the appropriate first-line agent for this presentation? Your options are A. Intravenous methylprednisolone for 7 days. B. Oral sulfasalazine. C. Subcutaneous methotrexate weekly. D. An anti-tumor necrosis factor biologic infusion. What's your answer? Commit to one before I continue. The correct answer is B. Oral sulfasalazine. B is correct because Crohn disease management begins with an oral aminosalicylate, such as sulfasalazine or mesalamine, to reduce mucosal inflammation. Stronger therapies are reserved for patients who fail or cannot tolerate this first step. A is wrong because intravenous corticosteroids are reserved for severe flares lasting 3 to 10 days, not initial therapy in mild disease. Starting at this level skips 2 earlier steps and exposes the patient to unnecessary systemic steroid risk. C is wrong because methotrexate is an immunosuppressive option used when aminosalicylates and steroids are not enough. It is not a starting agent for mild new onset disease. D is wrong because biologic agents are reserved for moderate to severe disease that has failed conventional therapy. Initiating them first ignores the stepwise approach and adds significant infection risk. Crohn disease is managed through a stepwise ladder, starting with the mildest effective therapy and escalating only when control is inadequate. The principle is simple: minimize cumulative toxicity over a lifetime of treatment. Aminosalicylates like sulfasalazine sit at the bottom rung, acting locally in the gut wall to inhibit prostaglandin and leukotriene synthesis. Antibiotics come next, then short-course steroids for flares, followed by immunosuppressants for maintenance, and finally biologics like anti-TNF agents for refractory or fistulizing disease. Long-term steroids cause osteoporosis, hyperglycemia, and adrenal suppression. Immunosuppressants and biologics raise the risk of opportunistic infection and malignancy. Starting low and escalating only by need keeps cumulative harm to a minimum over decades. Exam questions test the ladder in 2 directions. A mild new onset case points to step 1, while a severely ill patient already failing oral therapy points to intravenous steroids and then escalation. Recognizing where the patient sits on the ladder is the core skill being tested. Question 5. A nurse practitioner suspects celiac disease in a 35-year-old patient with chronic diarrhea, malabsorption, and dermatitis herpetiformis. Which combination of laboratory tests should be ordered to support the diagnosis? Your options are A. Antinuclear antibody and anti-double-stranded DNA. B. Perinuclear anti-neutrophil cytoplasmic antibody and anti-Saccharomyces cerevisiae antibody. C. EGA, a tissue transglutaminase and total EGA. D. HLA-B5801 allele. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is C. EGA tissue transglutaminase and total EG. C is correct because the standard initial workup for celiac disease is IgA tissue transglutaminase along with a total EGA level to rule out EGA deficiency, which would produce a falsely negative result. Confirming antibody and immunoglobulin status before biopsy is the recommended pathway. A is wrong because anti-nuclear and anti-double-stranded DNA antibodies are markers for systemic lupus erythematosus. They have no diagnostic role in celiac disease. B is wrong because PANSA and ASCA are antibody patterns used to differentiate ulcerative colitis from Crohn's disease. They do not assess gluten sensitivity. D is wrong because HLA-B5801 is a pharmacogenomic marker for severe cutaneous reactions to allopurinol. It is unrelated to celiac evaluation. The serologic workup for celiac disease follows a deliberate two-test strategy. Understanding why these specific tests are paired together reveals the underlying disease biology. Tissue transglutaminase is the central enzyme targeted by the immune system in genetically susceptible individuals. Pairing the antibody test with a total IgA level ensures that a patient who simply cannot produce IgA is not falsely cleared. When total IgA is normal, a positive TTG sends the workup straight to duodenal biopsy to confirm villus atrophy. When total IgA is low, the standard test loses its reliability and IgG-based alternatives must be used instead. Each antibody panel maps to a specific disease. IgA, TTG plus total IgA is celiac. ENA and ANTID's DNA point to lupus. ASCA and PANCA differentiate Crohn from ulcerative colitis. HLA-B5801 flags allopurinol toxicity risk. Mixing these panels is the classic exam trap. Whenever a clinical stem describes dermatitis herpetiformis, refractory iron deficiency anemia, or unexplained osteopenia in a young patient, the correct initial move is IgA tissue transglutaminase paired with total IgA. Size on gay metastases every time. Question 6. A 38-year-old patient presents with a 6-week history of unintentional weight loss despite increased appetite, palpitations, fine hand tremor, warm moist skin, and intolerance to heat. Which thyroid disorder best matches these findings? Your options are A. Hypothyroidism, B. Hypothyroidism, C. Adrenal insufficiency, D. Hypoparathyroidism. Which would you go with? Lock it in before the reveal. The correct answer is A. Hypothyroidism. A is correct because increased metabolic rate, weight loss with preserved appetite, tachycardia, tremor, warm moist skin, and heat intolerance are the classic signs of hypothyroidism. The body is running fast in every system at once. B is wrong because hypothyroidism produces the opposite picture: weight gain, cold intolerance, dry skin, fatigue, and bradycardia. The metabolism slows, not speeds. C is wrong because adrenal insufficiency causes hyperpigmentation, salt craving, hypotension, and fatigue. It does not produce a hypermetabolic clinical picture. D is wrong because hypoparathyroidism causes neuromuscular irritability with paresthesia, twitching, and muscle cramps from low calcium. It is not a hypermetabolic syndrome. Hypothyroidism occurs when excess thyroid hormones accelerate nearly every metabolic process in the body. Understanding the mechanism helps explain why so many organ systems are affected at once. Because thyroid hormones act on nearly every tissue, the symptoms appear together as a cluster. Recognizing this combination, especially weight loss despite eating more, is the key diagnostic signal. In Graves' disease, thyroid-stimulating immunoglobulin mimics TSH and locks onto the thyroid receptor without any feedback regulation. The gland enlarges and produces hormone continuously, while the pituitary suppresses its own TSH output in response to the rising hormone levels. Multiple conditions can cause hypothyroidism, but Graves' disease is uniquely identified by proptosis and pretibial myxedema. Regardless of the underlying cause, all forms share the downstream finding of suppressed TSH and elevated free thyroid hormones. When a patient is losing weight despite eating more, racing, trembling, and overheating all at once, the hypermetabolic profile points squarely to hyperthyroidism. The contrast with hypothyroidism, adrenal insufficiency, and hypoparathyroidism is sharp. None of those conditions speed the whole body up. Question 7. A patient is diagnosed with primary hypothyroidism after presenting with fatigue, cold intolerance, dry skin, and a TSH of 18 myela. Which medication is appropriate to initiate as first-line replacement therapy? Your options are A. Metimazole, B. Propylthiouracil, C. Calcitonin, D. Levothyroxine. Don't overthink it. Which one feels right? The correct answer is D. Levothyroxine. D is correct because levothyroxine is synthetic T4 and is the standard replacement therapy for hypothyroidism. It restores circulating thyroid hormone, lowers the elevated TSH, and reverses the hypometabolic symptoms. A is wrong because methimazole blocks thyroid hormone production and is used in hyperthyroidism. Giving it to a hypothyroid patient would worsen the deficiency. B is wrong because propylthiouracil is also an anti-thyroid agent indicated for hypothyroidism, particularly during pregnancy. It has no role in hypothyroidism. C is wrong because calcitonin is a calcium-regulating hormone used in hypercalcemia and certain bone diseases. It does not treat thyroid hormone deficiency. Hypothyroidism develops when the thyroid gland fails to produce enough hormone to meet the body's metabolic needs. The result is a global slowdown. Every system runs below its normal speed. The hallmark features reflect a metabolism stuck in low gear: fatigue, cold intolerance, weight gain, constipation, dry skin, bradycardia, and slowed thinking all point toward insufficient thyroid hormone. Levothyroxine is the inactive prohormone thyroxine. The body converts it peripherally to the active triiodothyronine. Its 7-day half-life creates forgiving pharmacokinetics, and the pituitary's TSH serves as the readout for dose titration every 6 to 8 weeks. The critical contrast: hyperthyroidism speeds everything up and is treated with methimazole or propylthiouracil, the opposite direction. Depression mimics fatigue and cognitive slowing but leaves thyroid labs normal. Adrenal insufficiency causes hypotension and hyperpigmentation, not weight gain and cold intolerance. When a patient presents with the body running slow in every system and labs show elevated TSH with low free thyroxine, levothyroxine is the answer. Titrate to a therapeutic TSH and the disease becomes fully manageable. Question 8. A patient who underwent a total thyroidectomy 2 days ago for Graves' disease develops fever to 104.2 F, heart rate of 162, agitation, and altered mental status. Which combination of treatments is appropriate for this thyroid emergency? Your options are A. Levothyroxine and intravenous calcium gluconate, B. Propylthiouracil, propranolol, and supportive care. C. Calcitonin and bisphosphonate therapy. D. Methotrexate and high-dose prednisone monotherapy. Got a guess? Lock it in. The correct answer is B. Propylthiouracil, propranolol, and supportive care. B is correct because thyroid storm is treated with propylthiouracil to block hormone synthesis and conversion, a beta blocker such as propranolol to control cardiovascular symptoms, and aggressive supportive care including cooling and fluids. Corticosteroids and iodine are typically added. A is wrong because levothyroxine adds more thyroid hormone, the opposite of what is needed in storm. Calcium replacement is irrelevant to acute hyperthyroid crisis. C is wrong because calcitonin and bisphosphonates manage hypercalcemia and bone loss, not a thyroid hormone surge. They have no role in thyroid storm. D is wrong because methotrexate is an immunosuppressant used in autoimmune and oncology settings, not in acute hyperthyroid emergencies. Prednisone alone is not adequate without anti-thyroid drug therapy. Thyroid storm is a rare but lethal amplification of hyperthyroidism, capable of killing within 48 hours. Understanding its mechanism, triggers, and treatment is essential to managing this true endocrine emergency. Storm doesn't arise from nowhere. A baseline of uncontrolled or undertreated hyperthyroidism is pushed over the edge by a physiologic stressor, infection, surgery, trauma, and untreated diabetic ketoacidosis are the most common triggers that unmask the underlying disease. Treatment is multimodal and must be time-sequenced. Propylthiouracil comes first to block synthesis and slow peripheral conversion of T4 to the more potent T3. A beta blocker tames the cardiovascular surge. Iodine must follow at least 1 hour later to block hormone release, and corticosteroids reduce conversion further while guarding against adrenal insufficiency. All four conditions share hypothermia and tachycardia, making them easy to confuse. The anchor for thyroid storm is a known or suspected thyroid history. Neuroleptic malignant syndrome adds muscular rigidity and an elevated creatine kinase. The exposure history is the key that separates each diagnosis. Whenever you see hypothermia above 104, severe tachycardia, and altered mental status together, ask about thyroid disease or recent thyroid surgery. That clinical triad plus a thyroid background points directly to storm and its multimodal treatment plan. Question 9. A patient with a strong family history of medullary thyroid cancer presents with a painless nodule on the anterior neck. Fine needle aspiration is suspicious for malignancy. Which genetic test is most appropriate to evaluate hereditary risk in this patient and first-degree relatives? Your options are A. Antithyroid peroxidase antibody, B. Thyroglobulin level, C. RET proto-oncogene mutation testing, D. BRCA1 and BRCA2 mutation panel. Which one is it? Pause the video if you need more time. The correct answer is C. RET proto-oncogene mutation testing. C is correct because medullary thyroid cancer arises from C cells and is strongly linked to mutations in the RET proto-oncogene located on chromosome 10. Identifying the mutation in patients and their first-degree relatives allows prophylactic thyroidectomy before disease develops. A is wrong because antithyroid peroxidase antibody screens for autoimmune thyroiditis, such as Hashimoto disease. It does not assess cancer risk. B is wrong because thyroglobulin tracks recurrence in differentiated thyroid cancer of follicular origin. It is not the marker for medullary thyroid cancer, which produces calcitonin. D is wrong because BRCA mutations are associated with breast and ovarian cancer risk, not medullary thyroid cancer. They are not part of the workup for thyroid C-cell malignancy. Medullary thyroid cancer is unique among thyroid malignancies because it arises from parafollicular C cells rather than follicular cells. These C cells produce calcitonin and carcinoembryonic antigen, making both markers central to diagnosis and surveillance. Unlike papillary and follicular cancers, medullary thyroid cancer does not concentrate radioactive iodine, so iodine ablation cannot be used. It also spreads earlier, giving it a disproportionately high mortality despite being relatively rare. About 1/4 of medullary thyroid cancer cases are hereditary, driven by germline mutations in the RET proto-oncogene. RET mutations also underlie MEN2A and MEN2B, which combine medullary thyroid cancer with pheochromocytoma and either parathyroid disease or mucosal neuromars, respectively. Once medullary thyroid cancer is confirmed, RET testing must extend to first-degree relatives. An asymptomatic carrier identified early can undergo prophylactic total thyroidectomy, essentially eliminating their lifetime cancer risk, a striking example of genetic counseling changing outcomes. Remember, calcitonin elevation plus a family history of thyroid cancer points to medullary thyroid cancer and mandates RET testing. Identifying carriers before malignancy develops is one of medicine's clearest wins for hereditary cancer prevention. Question 10. A 45-year-old woman presents with progressive fatigue, weight gain, cold intolerance, dry skin, constipation, and a diffusely enlarged but non-tender thyroid. Laboratory testing shows elevated TSH, low free T4, and high anti-thyroid peroxidase antibodies. Which disorder best fits this presentation? Your options are A. Hashimoto thyroiditis, B. Graves' disease, C. Thyroid storm, D. Medullary thyroid cancer. Take a second. Which answer would you pick? The correct answer is A. Hashimoto thyroiditis. L is correct because Hashimoto thyroiditis is the most common cause of primary hypothyroidism in adults and is driven by antibodies that gradually destroy thyroid tissue. Elevated antithyroid peroxidase antibodies, hypometabolic symptoms, and a goiter without tenderness are the classic combination. B is wrong because Graves' disease causes hyperthyroidism with weight loss, heat intolerance, and tachycardia. The lab pattern shows suppressed TSH and elevated free hormones, not the opposite. C is wrong because thyroid storm is an acute, life-threatening surge of thyroid hormones with hypothermia, tachycardia, and altered mental status. It is not a chronic insidious illness. D is wrong because medullary thyroid cancer presents as a solitary painless nodule with elevated calcitonin, not diffuse goiter and hypothyroid symptoms. Hashimoto thyroiditis is the leading cause of primary hypothyroidism in adults living in iodine-sufficient countries. It's a chronic autoimmune disease in which the immune system gradually destroys the thyroid gland over years. The damage is driven by cytotoxic T cells and antibodies against thyroid peroxidase and thyroglobulin. As follicular cells are destroyed, thyroid hormone output falls and TSH rises in a futile attempt to compensate, producing the classic hypermetabolic state. Early in the disease, a brief hypothyroid phase can occur as stored hormone leaks from damaged follicles, but the dominant trajectory is a slow, relentless decline in thyroid function leading to the full hypothyroid picture of fatigue, weight gain, cold intolerance, dry skin, and bradycardia. Diagnosis requires combining the clinical picture with 4 laboratory and exam findings: elevated TSH, low free T4, strongly positive anti-TPO antibodies, and a diffusely enlarged firm thyroid on exam. Hashimoto also clusters with other autoimmune conditions like type 1 diabetes and vitiligo. When the exam stem describes an insidious hypometabolic slowdown with a goiter and positive anti-TPO antibodies, the answer is Hashimoto thyroiditis and treatment is levothyroxine. Question 11. A nurse is preparing to administer a rapid-acting insulin to a hospitalized patient about to eat lunch in 10 minutes. The patient is on a basal bolus regimen and the order specifies the insulin be given as the prandial dose. Which insulin best fits this timing requirement? Your options are A. Regular insulin, B. Lispro, C. Npage, D. Glargine. Before I reveal it, which one do you think is right? The correct answer is B, Lispro. B is correct because Lispro is a rapid-acting insulin analog with onset under 15 minutes and peak effect at 30 to 90 minutes, making it ideal to give immediately before a meal. The timing matches the carbohydrate absorption window almost exactly. A is wrong because regular insulin has an onset of 30 to 60 minutes and peaks at 2 to 4 hours. Given 10 minutes before food, it would peak well after the meal is digested, raising the risk of late hypoglycemia. C is wrong because NPH is intermediate acting with an onset of 1 to 1.5 hours and a duration of about 24 hours. It is used as background coverage, not for prandial control. D is wrong because Glargine is long-acting basal insulin with an onset of about 60 to 70 minutes and no peak. It is dosed once daily for steady background coverage and should never be used as a meal bolus. Safe insulin use depends on matching the right formulation to the right moment. Each insulin type has a distinct onset, peak, and duration that determines when and how blood glucose falls. Healthy beta cells release a continuous basal trickle all day and sharp bolus surges around meals. Modern insulin regimens recreate this pattern by pairing a long-acting basal insulin with rapid-acting mealtime boluses. Rapid-acting analogues like Lispro and Aspart onset in under 15 minutes, making them ideal for injecting right before a meal. Regular insulin peaks too late at 2 to 4 hours to match postprandial glucose. NPH provides intermediate background coverage, while Glargine delivers a peakless 24-hour profile. The speed differences come down to molecular structure at the injection site. Regular insulin clumps into hexamers that must break apart before absorption. Lispro's 2 reversed amino acids prevent hexamer formation, enabling rapid uptake. NPH adds protamine to slow release, and Glargine forms microcrystals at physiologic pH for a steady, peakless effect. When a clinical scenario specifies meal timing or basal coverage, the pharmacokinetic profile points directly to the correct choice. Anchor each agent to its onset, peak, and duration, and you eliminate the most common insulin prescribing errors. Question 12. An 18-year-old with type 1 diabetes is brought to the emergency department with nausea, vomiting, deep rapid breathing, fruity scented breath, and altered mental status. Capillary blood glucose is 412 mg/dL and urine ketones are large. Which diagnosis fits this clinical picture? Your options are A. Hypoglycemic crisis, B. Thyroid storm, C. Hyperosmolar hyperglycemic state, D. Diabetic ketoacidosis. What's your answer? Commit to one before I continue. The correct answer is D. Diabetic ketoacidosis. D is correct because hyperglycemia above 300, large ketones, deep cosmal respirations, fruity breath, and altered mental status in a type 1 diabetic are the classic features of diabetic ketoacidosis. Insulin deficiency drives lipolysis and the resulting acidosis. A is wrong because hypoglycemic crisis presents with low glucose, sweating, tremor, and confusion that resolves with sugar. Glucose over 400 rules it out completely. B is wrong because thyroid storm produces hypothermia, tachycardia, and agitation, but is not associated with hyperglycemia or ketoacidosis. C is wrong because hyperosmolar hyperglycemic state produces extreme hyperglycemia and dehydration, but ketones are typically minimal and it occurs in older type 2 diabetics, not adolescents with type 1. Diabetic ketoacidosis, or DKA, is a life-threatening emergency that arises from insulin deficiency. When cells cannot access glucose, the body shifts into a starvation-like state with dangerous consequences. The diagnosis rests on 3 findings together: blood glucose above 300, circulating ketones, and a metabolic acidosis with an elevated anion gap. No single finding alone is sufficient. You need all 3. Without insulin, counter-regulatory hormones surge and drive massive fat breakdown. The liver converts free fatty acids into ketone bodies, beta-hydroxybutyrate and acetoacetate, which drop blood pH directly. Meanwhile, soaring glucose pulls water and electrolytes into the urine through osmotic diuresis. Clinically, the patient breathes deeply and rapidly, small respirations, as the lungs try to blow off carbon dioxide to compensate for the acidosis. The breath smells fruity from acetone. Dehydration and worsening acidosis impair consciousness. Treatment follows a strict sequence: aggressive IV fluid resuscitation first, then regular insulin infusion, then careful potassium replacement, because insulin shifts potassium intracellularly and can cause dangerous hypokalemia. Always identify and treat the underlying precipitant. Question 13. A patient with type 2 diabetes is newly diagnosed with hypertension. The provider plans to begin antihypertensive therapy and considers renal protection in the choice. Which medication class is the appropriate first-line treatment for this patient? Your options are A. Hydrochlorothiazide, B. Metoprolol, C. Captopril, D. Amlodipine. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is C. Captopril. C is correct because an ACE inhibitor such as captopril is the recommended first-line antihypertensive in diabetes because it lowers blood pressure while also reducing intraglomerular pressure and slowing diabetic nephropathy. Renal protection is the key reason this class is preferred. A is wrong because thiazide diuretics lower blood pressure but do not provide the same renal protective benefit and can worsen glycemic control through modest hyperglycemia. B is wrong because beta blockers lower blood pressure but mask the adrenergic warning signs of hyperglycemia, which is a significant concern in insulin-treated diabetics. D is wrong because calcium channel blockers are useful add-ons in stage 3 chronic kidney disease, but are not the recommended first agent in early diabetic hypertension. When a diabetic patient is diagnosed with hypertension, the drug choice goes beyond just lowering blood pressure. The same vascular stress driving high blood pressure is also damaging the kidneys, so the ideal agent does both jobs at once. ACE converts angiotensin 1 to angiotensin 2, which constricts the efferent renal arteriole and raises pressure inside the glomerulus. Blocking ACE drops both systemic blood pressure and intraglomerular pressure simultaneously, slowing the kidney damage that defines diabetic nephropathy. Large trials in the 90s and 2000s confirmed that ACE inhibitors outperformed other equally effective antihypertensives in diabetic patients. They reduced proteinuria, slowed nephropathy progression, and cut cardiovascular events, making them first line by guideline consensus. Each antihypertensive class has a preferred patient type. Beta blockers carry the added concern of masking hypoglycemia in insulin-treated diabetics. Calcium channel blockers are useful add-ons later in chronic kidney disease, but are not the starting choice when diabetes is present. When an exam stem combines diabetes with hypertension or microalbuminuria, the answer is an ACE inhibitor or angiotensin receptor blocker. The one key exception is pregnancy, where these agents are contraindicated and methyl-dopa or labetalol are used instead. Question 14. A patient with type 1 diabetes is being started on metoprolol for supraventricular tachycardia. The nurse teaches the patient about a specific concern related to combining a beta blocker with insulin therapy. Which point is the priority in this teaching? Your options are: A. Beta blockers can mask the adrenergic warning signs of hypoglycemia. B. Beta blockers cause sustained hyperglycemia that requires increased insulin doses. C. Beta blockers worsen ketoacidosis through direct effects on lipolysis. D. Beta blockers prevent insulin from binding at peripheral receptors. Which would you go with? Lock it in before the reveal. The correct answer is A. Beta blockers can mask the adrenergic warning signs of hypoglycemia. A is correct because beta blockers blunt sympathetic responses, which suppresses the tremor, tachycardia, and anxiety that normally warn a diabetic patient that glucose is dropping. Sweating may still occur, but the patient loses the usual early signals and may progress to severe hypoglycemia before recognizing it. B is wrong because beta blockers can produce mild glycemic effects but do not cause sustained dangerous hyperglycemia. The clinical concern lies in masked lows, not elevated glucose. C is wrong because beta blockers do not directly worsen ketoacidosis. The lipolysis pathway in DKA is driven by insulin deficiency and counter-regulatory hormones, not adrenergic blockade. D is wrong because beta blockers act on adrenergic receptors and have no effect on insulin receptor binding. The mechanism described is incorrect. When a patient on insulin starts a beta blocker, a hidden danger emerges. The interaction isn't pharmacokinetic. It's about the body's own warning system for low blood sugar being silenced. Normally, falling glucose triggers a cascade. Glucagon rises first. Then epinephrine produces the familiar warning signs: tremor, rapid heart rate, palpitations. Patients learn to recognize this adrenergic phase and treat themselves before confusion sets in. Beta blockers interrupt exactly that step. Beta 1 blockade suppresses tachycardia. Beta 2 blockade blunts tremor and palpitations. Crucially, sweating often persists because it is cholinergically mediated, but it cannot be relied on alone as a warning sign. Among antihypertensives used in diabetic patients, ACE inhibitors are preferred for renal protection. Calcium channel blockers are metabolically neutral, and thiazides carry mild risk. Beta blockers are unique. They carry the specific danger of hiding a glucose emergency entirely. When a beta blocker is added to insulin therapy, the priority teaching is this: the familiar adrenergic warning signs will be blunted. The patient must monitor glucose more frequently, especially before driving, during exercise, and after any dose change. Question 15. A patient with primary adrenal insufficiency requires a mineralocorticoid for replacement therapy in addition to glucocorticoid coverage. Which medication is most appropriate for this purpose? Your options are methimazole, B. Fludrocortisone, C. Calcitonin, D. Alendronate. Don't overthink it. Which one feels right? The correct answer is B. Fludrocortisone. B is correct because fludrocortisone is a mineralocorticoid used to replace aldosterone in Addison disease and adrenocortical insufficiency. It restores sodium retention, potassium excretion, and blood pressure regulation that the failing adrenal cortex cannot provide. A is wrong because methimazole is an anti-thyroid agent that blocks thyroid hormone synthesis. It has no role in adrenal hormone replacement. C is wrong because calcitonin lowers serum calcium and is used in hypercalcemia and Paget disease. It does not address aldosterone deficiency. D is wrong because alendronate is a bisphosphonate used to treat osteoporosis and slow bone resorption. It does not replace adrenal hormones. Fludrocortisone is a synthetic mineralocorticoid that steps in when the adrenal cortex can no longer produce aldosterone on its own. Understanding why it's needed requires knowing what happens when the entire adrenal cortex is destroyed. In Addison disease, both glucocorticoid and mineralocorticoid output collapse. The resulting sodium loss, potassium retention, and volume depletion produce the classic picture of hypotension, hyponatremia with hyperkalemia, and the striking hyperpigmentation driven by compensatory ACTH excess. Fludrocortisone binds the mineralocorticoid receptor in renal collecting duct cells, mirroring endogenous aldosterone almost exactly. Sodium and water are reabsorbed back into the bloodstream, restoring volume and blood pressure, while potassium and hydrogen ions are excreted into the urine. Treatment must cover both deficits. Hydrocortisone or prednisone replaces glucocorticoid function, while fludrocortisone replaces mineralocorticoid function. Together they restore what an intact adrenal cortex would regulate automatically. No other drug in routine clinical use replaces aldosterone. When an exam stem describes Addison disease with hyponatremia, hyperkalemia, and salt craving, fludrocortisone is the mineralocorticoid answer, so distinct from thyroid drugs, bisphosphonates, or calcitonin, which act on entirely different endocrine pathways. Question 16. A patient with chronic congestive heart failure presents with bilateral lower extremity pitting edema, abdominal distension, jugular venous distension, and an enlarged tender liver. Lung sounds are clear bilaterally and there is no orthopnea. Which type of heart failure best matches these findings? Your options are A. Reduced ejection fraction systolic failure with pulmonary congestion, B. Acute pulmonary embolism with right heart strain, C. Pulmonary edema from acute left-sided failure, D. Right-sided heart failure. Got a guess? Lock it in. The correct answer is D. Right-sided heart failure. D is correct because right-sided heart failure produces peripheral congestion, lower extremity edema, abdominal distension, jugular venous distension, and hepatic engorgement. The lungs are typically clear because the backup is into the systemic venous system, not the pulmonary circulation. A is wrong because reduced ejection fraction failure usually presents with prominent left-sided signs such as crackles, S3 gallop, and orthopnea. The picture described shows clear lungs and systemic venous congestion instead. B is wrong because acute pulmonary embolism causes sudden dyspnea, pleuritic chest pain, and hypoxemia rather than chronic peripheral edema and abdominal distension. C is wrong because left-sided failure causes pulmonary edema with crackles, dyspnea, and orthopnea. The absence of these findings argues against this diagnosis. Right-sided heart failure occurs when the right ventricle can't push venous blood forward into the lungs. Instead, blood backs up into the systemic veins, raising central venous pressure and producing a very distinct pattern of congestion. The key to localizing heart failure is understanding which ventricle pumps into which circulation. The right ventricle feeds the pulmonary arteries, so when it fails, congestion is systemic. The left ventricle feeds the body, so when it fails, congestion floods the lungs. The hallmark findings all reflect venous backup on the systemic side. Critically, lung sounds remain clear because the congestion never reaches the pulmonary circulation. This clear lungs detail is the key differentiator on the exam. The most common cause of right-sided failure is actually left-sided failure. Chronic left ventricular dysfunction raises pulmonary pressures until the right ventricle is exhausted. Other causes include cor pulmonale from COPD, primary pulmonary hypertension, right ventricular infarction, and tricuspid valve disease. Wenner-Stem describes jugular venous distension, peripheral edema, hepatomegaly, and clear lungs together. Right-sided failure fits the picture. Pulmonary findings without systemic congestion point left. Both together means biventricular failure. Question 17. A neonate is born with hypoplastic left heart syndrome and is scheduled for the first stage of surgical repair within the first 1 to 2 weeks of life. The cardiothoracic team plans to enlarge the aorta, attach it to the right ventricle, create a shunt to the pulmonary artery, and close the patent ductus arteriosus. Which procedure does this describe? Your options are A. Norwood procedure, B. Glenn procedure, C. Fontan procedure, D. Isolated heart transplantation. Which one is it? Pause the video if you need more time. The correct answer is A. Norwood procedure. A is correct because the Norwood procedure is stage 1 in the surgical pathway for hypoplastic left heart syndrome and is performed in the first 1 to 2 weeks. It enlarges the aorta, connects it to the right ventricle, creates a shunt to the pulmonary artery, and closes the ductus arteriosus. B is wrong because the Glenn procedure is stage 2, performed at 4 to 6 months, and connects the superior vena cava to the pulmonary artery while removing the prior shunt. It is not the first procedure. C is wrong because the Fontan procedure is stage 3, completed at 18 to 36 months, and connects the inferior vena cava to the pulmonary artery to complete the single ventricle circulation. It is the last step, not the first. D is wrong because isolated heart transplantation may eventually be needed, but is not the standard first stage repair, which is the staged Norwood reconstruction. Hypoplastic left heart syndrome is a congenital defect where the entire left side of the heart fails to develop. The left ventricle, mitral valve, aortic valve, and ascending aorta are all underdeveloped or absent, making independent systemic circulation impossible without intervention. Survival became possible only after William Norwood introduced staged surgical palliation in 1983. The repair is built across 3 procedures spaced over the first 3 years of life, progressively redirecting venous blood to the lungs without relying on a left ventricle at all. Each stage has a distinct timing and anatomical goal. The Norwood establishes the right ventricle as the systemic pump. The Glenn connects the superior vena cava to the pulmonary artery. The Fontan completes the circuit by adding the inferior vena cava, creating a fully passive Fontan circulation. It is important not to confuse hypoplastic left heart syndrome with other cyanotic congenital lesions. Transposition requires an arterial switch. Tetralogy of Fallot involves right ventricular outflow obstruction, and coarctation requires repair of a discrete aortic segment. Each defect carries its own anatomy, surgery, and timeline. When an exam stem describes a newborn with an underdeveloped left heart started on prostaglandin E1, the first surgical step within 2 weeks is always the Norwood. Transplantation is not the routine first stage pathway. One staged palliation is. Question 18. A patient experiences a sudden drop in arterial blood pressure after a hemorrhagic event. The kidneys play a central role in restoring blood pressure through hormonal mechanisms that increase sodium and water reabsorption. Which mechanism is most directly responsible for this response? Your options are A. Decreased antidiuretic hormone leading to increased natriuresis, B. Increased thyroid hormone production stimulating peripheral vasoconstriction. C. Renin-angiotensin-aldosterone system activation increasing sodium and water reabsorption. D. Decreased aldosterone leading to increased renal sodium loss. Take a second. Which answer would you pick? The correct answer is C. Renin-angiotensin-aldosterone system activation increasing sodium and water reabsorption. C is correct because when blood pressure falls, the kidneys release renin, which generates angiotensin II, a powerful vasoconstrictor, and stimulates aldosterone release from the adrenal cortex. Aldosterone increases sodium and water reabsorption, restoring intravascular volume and pressure. A is wrong because ADH actually rises in response to hypovolemia and acts on the collecting duct to retain water. Decreased ADH would worsen the situation. B is wrong because thyroid hormone influences metabolic rate but is not the acute regulator of blood pressure after volume loss. D is wrong because aldosterone increases, not decreases, in response to hypovolemia. Lower aldosterone would cause sodium wasting and worsen the pressure drop. The renin-angiotensin-aldosterone system is the kidney's primary tool for restoring blood pressure after volume loss. Understanding how each step connects helps you predict both the physiology and the pharmacology. Renin cleaves angiotensinogen into angiotensin OA, and ACE in the lung converts that into angiotensin II, the active hormone. Angiotensin then drives vasoconstriction, triggers aldosterone and ADH release, and stimulates thirst. Aldosterone completes the loop by increasing sodium and water reabsorption at the collecting duct. It helps to contrast RAS with the other pressure-raising systems. The sympathetic nervous system acts immediately through vasoconstriction and increased heart rate. ADH supports pressure through water retention. RAS is unique in targeting sodium balance and sustaining the response over time. When a question describes hemorrhage, hypertension, or oliguria, the RAAS is the central regulator to reach for. Decreased aldosterone or decreased ADH describe the opposite response. Classic wrong answer traps on the exam. Question 19. A 19-year-old collegiate distance runner presents for a routine sports physical examination. He is asymptomatic, well-conditioned, and has a resting heart rate of 42 with no murmurs and a normal electrocardiogram. He denies syncope, chest pain, and palpitations. Which response is most appropriate? Your options are A. Refer immediately for permanent pacemaker evaluation. B. Document athletic heart syndrome and clear him for participation. C. Order cardiac catheterization to rule out structural disease. D. Begin atropine to raise the resting heart rate. Before I reveal it, which one do you think is right? The correct answer is B. Document athletic heart syndrome and clear him for participation. B is correct because athletic heart syndrome is an expected adaptation in highly conditioned athletes, with resting heart rates as low as 30 to 40 and an enlarged but functional heart. With a normal exam, normal EKG, and no symptoms, the athlete is cleared and the bradycardia is documented as expected. A is wrong because pacemaker placement is reserved for symptomatic bradycardia or pathologic conduction disease, neither of which is present here. Surgery would be inappropriate intervention. C is wrong because cardiac catheterization is invasive and indicated when there is evidence of coronary disease or structural pathology. A normal exam and EKG do not justify it. D is wrong because atropine is used acutely for symptomatic bradycardia. An asymptomatic athlete with physiologic bradycardia does not need pharmacologic heart rate elevation. Athletic heart syndrome is a cluster of structural and electrical changes that develop as the cardiovascular system adapts to years of endurance training. It's a normal physiologic response, not a disease. Sustained endurance training enlarges the left ventricular cavity, allowing more blood to be ejected with each beat. Because stroke volume rises, fewer beats per minute are needed at rest, producing resting heart rates as low as 30 to 40 beats per minute through increased vagal tone. The critical clinical skill is distinguishing athletic heart from genuine pathology. Hypertrophic cardiomyopathy produces asymmetric thickening and carries sudden death risk. Sick sinus syndrome and AV block cause symptomatic bradycardia in older patients with conduction disease. Both may require pacemakers. When a young, asymptomatic, well-conditioned athlete presents with bradycardia and a normal ECG, the answer is reassurance and clearance. The picture changes only when red flags appear. Syncope, chest pain, or a family history of sudden cardiac death. What's a cerebral, which warrant further cardiac evaluation? Question 20. A 55-year-old patient has been seen on 3 separate occasions over 6 weeks with consistently elevated blood pressure readings of 152 to 96, 5 to 94, and 150/92. There is no identifiable secondary cause after a complete workup. Which diagnosis best fits these findings? Your options are A. Elevated blood pressure, B. Stage 1 hypertension, C. Secondary hypertension from renal artery stenosis, D. Stage 2 primary hypertension. What's your answer? Commit to one before I continue. The correct answer is D. Stage 2 primary hypertension. D is correct because stage 2 hypertension is defined as systolic pressure of 140 or higher, or diastolic pressure of 90 or higher, with no underlying cause identified after workup. The disease is classified as primary, and these consistent readings firmly meet stage 2 criteria. A is wrong because elevated blood pressure refers to systolic readings of 120 to 129, with diastolic under 80. The readings here are far above that range. B is wrong because stage 1 hypertension covers systolic 130 to 139 or diastolic 80 to 89. The pressures here exceed those thresholds. C is wrong because secondary hypertension implies an underlying cause such as renal artery stenosis, primary aldosteronism, or sleep apnea. The workup specifically ruled these out. Primary hypertension is a sustained rise in blood pressure with no identifiable underlying cause. Unlike secondary hypertension, where a specific condition drives the pressure up, primary hypertension emerges gradually from a web of genetic and lifestyle factors over many years. The mechanism is multifactorial. Salt sensitivity, sympathetic nervous system overactivity, renin-angiotensin-aldosterone activation, endothelial dysfunction, and obesity-related insulin resistance all contribute to different degrees in different patients, producing a steady rise in peripheral vascular resistance over years. The ACC and HA define 4 categories. Normal sits below at 20 over 80. Elevated spans 120 to 129 systolic with diastolic under 80. Stage 1 covers 130 to 139 over 80 to 89. Stage 2 begins at 140 over 90 or higher, the threshold that triggers pharmacologic treatment alongside lifestyle changes. Before labeling hypertension as primary, secondary causes must be excluded. Renal artery stenosis, primary aldosteronism, pheochromocytoma, and obstructive sleep apnea are the high-yield culprits on exams. Identifying any of these shifts the diagnosis to secondary hypertension, and treatment targets the underlying cause directly. The exam key is simple: 2 or more readings at or above 140 over 90 on separate occasions, with secondary causes ruled out. Define stage 2 primary hypertension. White coat hypertension is the trap. Office readings are elevated, but home or ambulatory monitoring is normal. Question 21. A patient with mild intermittent asthma reports symptoms only during high pollen days and after vigorous exercise. Symptoms resolve quickly with short-term relief therapy and the patient has no nighttime awakenings. Which step 1 treatment plan is appropriate for this patient? Your options are A. Albuterol metered dose inhaler used as needed before known triggers. B. Daily oral prednisone tapered over 4 weeks. C. Twice daily fluticasone and salmeterol combination inhaler. D. Theophylline taken every morning. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is A. Albuterol metered dose inhaler used as needed before known triggers. A is correct because step 1 asthma management for intermittent symptoms uses a short-acting beta agonist such as albuterol on an as-needed basis. It opens the airways during exposures or exercise without exposing the patient to chronic medication. B is wrong because oral steroids are reserved for severe exacerbations or step 6 daily oral therapy. Daily prednisone for mild intermittent asthma exposes the patient to substantial side effects unnecessarily. C is wrong because combination inhaled corticosteroid plus long-acting beta agonist is appropriate at higher steps when symptoms are persistent and uncontrolled with lower step therapy. It is not a starting choice. D is wrong because theophylline is an add-on agent used when standard therapy is inadequate. It is not a first-line monotherapy for mild intermittent disease. Asthma therapy follows a stepwise framework where treatment intensity is matched to symptom frequency and severity. The goal is always to use the lowest step that adequately controls symptoms, stepping up when control is lost and stepping down when it is maintained. Each step adds a controller medication when symptoms cross a frequency threshold. Steps 4 through 6 are reserved for persistent or refractory disease, layering on long-acting beta agonists, higher dose inhaled steroids, and ultimately oral corticosteroids. Short-acting beta agonists like albuterol work within minutes by stimulating beta-2 adrenergic receptors on airway smooth muscle. This activates adenylate cyclase, raises intracellular cyclic AMP, and produces rapid bronchodilation lasting 4 to 6 hours. Critically, SABAs treat bronchoconstriction only. They do not address underlying inflammation. Exam stems describing mild intermittent asthma point to step 1. Look for infrequent daytime symptoms, no nocturnal awakenings, and rapid relief from a rescue inhaler. Daily controllers like inhaled corticosteroids or combination inhalers are inappropriate at this step and belong to higher rungs of the ladder. Question 22. A patient with chronic obstructive pulmonary disease has been stable on a daily long-acting muscarinic antagonist, but is now experiencing more frequent exacerbations and worsening dyspnea. According to a stepwise gold-style approach, which adjustment is most appropriate at this point? Your options are A. Begin daily oral prednisone indefinitely. B. Switch to a short-acting beta agonist taken as needed only. C. Add a long-acting beta agonist to the existing long-acting muscarinic antagonist. D. Discontinue all inhalers and rely on supplemental oxygen alone. Which would you go with? Lock it in before the reveal. The correct answer is C. Add a long-acting beta agonist to the existing long-acting muscarinic antagonist. C is correct because when a long-acting muscarinic antagonist alone fails to control COPD symptoms and exacerbations, the next step is to add a long-acting beta agonist for combined bronchodilation. Dual bronchodilator therapy improves airflow and reduces exacerbations. A is wrong because chronic oral steroids are reserved for advanced disease and carry serious systemic risks, including infection, osteoporosis, and hyperglycemia. They are not the next step. B is wrong because stepping down to as-needed short-acting therapy would worsen control in a patient who is already escalating. The direction of therapy is upward, not downward. D is wrong because stopping inhalers and using oxygen alone removes the bronchodilation that this patient depends on. Oxygen treats hypoxemia, but does not treat airflow obstruction. COPD combines chronic bronchitis and emphysema, both of which trap air and obstruct airflow. Understanding why two separate bronchodilator classes work better together is the core principle here. Chronic bronchitis inflames and clogs the airways, while emphysema destroys the tiny air sacs where gas exchange happens. Together they create persistent, progressive airflow obstruction that worsens over time. The GOLD guidelines organize treatment as a stepwise escalation. You start with a long-acting muscarinic antagonist, then add a long-acting beta agonist when control is insufficient, and reserve triple therapy, adding an inhaled corticosteroid for the highest risk patients. Long-acting muscarinic antagonists block parasympathetic acetylcholine signaling, reducing bronchoconstrictor tone. Long-acting beta agonists independently stimulate beta-2 receptors and raise cyclic AMP, directly relaxing smooth muscle. Because these are parallel pathways, combining them opens the airways more than either drug alone. When a patient on a single long-acting bronchodilator returns with worsening dyspnea or frequent exacerbations, the next step is adding the complementary class. Daily oral steroids and short-acting agents are the wrong direction at this stage of the algorithm. Question 23. A patient who is HIV positive receives a tuberculin skin test as part of routine screening. At 72 hours, the induration measures 7 millimeters. The patient denies cough, fever, weight loss, or known TB exposure. Which interpretation is correct? Your options are A. Negative result that requires no further workup. B. Positive result requiring chest imaging and clinical evaluation. C. Equivocal result that should be repeated in 2 weeks. D. Reaction caused by prior bacille Calmette-Guerin vaccination. Don't overthink it. Which one feels right? The correct answer is B. Positive result requiring chest imaging and clinical evaluation. B is correct because for immunocompromised patients, including those with HIV, an induration of 5 millimeters or greater is considered positive. 7 millimeters in this patient meets the threshold and requires chest imaging and clinical evaluation for active disease. A is wrong because a negative interpretation would be appropriate only in low-risk healthy individuals where a 15 millimeter cutoff applies. The lower threshold for HIV-positive patients makes 7 millimeters positive. C is wrong because repeating the test in 2 weeks is not the standard approach for an induration that already exceeds the cutoff. The reaction is interpreted at 48 to 72 hours. D is wrong because bacille Calmette-Guerin vaccination can cause a positive skin test, but it is not assumed when the patient is immunocompromised. The cutoff for HIV-positive patients still applies. The tuberculin skin test screens for immune memory against Mycobacterium tuberculosis by provoking a delayed type hypersensitivity reaction. Understanding how it works and how to interpret the result depends on knowing the patient's risk category. Tuberculin antigen is injected into the dermis, where sensitized memory T cells recognize it, recruit macrophage, and generate localized inflammation. This produces a palpable raised induration, not just redness, and it is measured at 48 to 72 hours after injection. The cutoff for a positive result shifts based on risk. 15 millimeters applies to healthy low-risk individuals. 10 millimeters applies to healthcare workers, immigrants, and congregate settings. 5 millimeters applies to HIV-positive patients, recent close contacts, and those on immunosuppressive therapy. The tuberculin skin test detects immune memory but can be falsely positive after BCG vaccination. Interferon gamma release assays offer a blood-based alternative unaffected by BCG. Sputum smear and culture are reserved for confirming active pulmonary disease. When the exam gives you a risk factor like HIV or recent contact, apply the lower cutoff. A 7 mm result is negative in a healthy person, but positive in an immunocompromised patient, and Mickey Cray, and that distinction drives clinical action. Question 24. A 68-year-old patient with diabetes presents with productive cough, fever to 102.4F, dyspnea, and pleuritic chest pain. Chest radiograph shows focal consolidation in the right lower lobe, and laboratory work shows leukocytosis with a leftward shift. Which diagnosis best fits this presentation? Your options are A. Viral pneumonia, B. Acute pulmonary edema from heart failure, C. Tuberculosis with cavitary disease, D. Bacterial community-acquired pneumonia. Got a guess? Lock it in. The correct answer is D. Bacterial community-acquired pneumonia. D is correct because focal lobar consolidation, productive cough, fever, pleuritic pain, and leukocytosis with a leftward shift are the textbook features of bacterial community-acquired pneumonia. Streptococcus pneumoniae is the most common pathogen. A is wrong because viral pneumonia produces diffuse, widespread interstitial whitening on chest film rather than focal consolidation, and white cell count is usually normal or low. B is wrong because pulmonary edema causes bilateral perihilar opacities, curly B lines, and signs of cardiac dysfunction. It does not produce focal consolidation with leukocytosis. C is wrong because tuberculosis classically causes upper lobe disease and cavitation rather than acute lower lobe consolidation, and it presents with chronic cough, night sweats, and weight loss. Community-acquired pneumonia is a lung infection that develops outside of a hospital setting and remains one of the leading infectious causes of death in older adults. Understanding its underlying mechanism helps explain the classic clinical and radiographic findings. Streptococcus pneumonia is the most frequent bacterial culprit, but atypical organisms and viruses also play important roles. Viral infections like influenza A can cause pneumonia directly or weaken the airway defenses, allowing bacterial superinfection to follow. When bacteria invade the lung, neutrophils, fibrin, and fluid flood the alveoli and replace the normal air spaces with dense exudate. This consolidation appears on chest radiograph as a focal lobar opacity, often with air bronchograms, where air-filled bronchi stand out against the surrounding solid tissue. Bacterial cap produces focal lobar consolidation with leukocytosis and a leftward shift. Viral pneumonia shows diffuse bilateral interstitial infiltrates with a normal or low white count. Cardiogenic pulmonary edema causes bilateral perihilar opacities with cardiac signs and no fever. Tuberculosis is a chronic upper lobe process with cavitation, weight loss, and night sweats. When you see productive cough, pleuritic chest pain, focal lobar consolidation, and leukocytosis with a leftward shift developing over 1 to 2 days, bacterial community-acquired pneumonia fits best and antibiotics are the priority. Question 25. A trauma patient arrives with absent breath, sounds on the left side, hyperresonance to percussion across the entire left chest, and tracheal deviation toward the right. Oxygen saturation is dropping rapidly. Which diagnosis best fits these findings? Your options are A. Tension pneumothorax, B. Hemothorax, C. Pleural effusion, D. atelectasis from mucus plugging. Which one is it? Pause the video if you need more time. The correct answer is A, tension pneumothorax. A is correct because pneumothorax produces absent or diminished breath sounds with hyperresonance on percussion, because air sits between the lung and chest wall. When the air is under tension and shifts the trachea, the patient is in life-threatening physiology requiring immediate decompression. B is wrong because hemothorax produces dullness to percussion because blood, not air, fills the pleural space. Hyperresonance argues against this diagnosis. C is wrong because pleural effusion also produces dullness, decreased fremitus, and decreased breath sounds. The percussion finding does not match. D is wrong because atelectasis usually produces dullness or normal percussion with diminished breath sounds and possible tracheal deviation toward the affected side, the opposite of what is described. To understand pneumothorax, we need to understand the pleural space, the potential space between the visceral and parietal pleura surrounding the lung. Normally the space is empty, but air, blood, or fluid can accumulate there with very different physical consequences. When air enters the pleural space, it conducts vibration very differently than fluid or blood. Tapping over an air-filled cavity produces a hyperresonant, almost tympanic sound, while fluid or blood produces a dull thud. The percussion note alone tells you what is filling the space. All four diagnoses share decreased breath sounds and decreased fremitus, but percussion separates them. Only pneumothorax is hyperresonant, the other three are dull. Atelectasis also causes tracheal deviation toward the affected side, while pneumothorax and tension pneumothorax push the trachea away. Tension pneumothorax develops when accumulating air under pressure shifts the mediastinum away from the affected side and compresses the heart and great vessels. The combination of tracheal deviation away from the affected side, absent breath sounds, and rapidly falling oxygen saturation demands immediate needle decompression before imaging. The single most important distinguishing clue is the percussion note. Hyperresonance means air in the pleural space, pneumothorax. Dullness means fluid, hemothorax or effusion. When you pair percussion with tracheal deviation and breath sounds, the diagnosis becomes clear. Question 26. A 70-year-old patient is newly diagnosed with mild Alzheimer disease and is starting first-line pharmacologic treatment. The patient is otherwise healthy and there are no contraindications. Which medication is the most appropriate initial choice? Your options are A. Memantine alone at maximum dose, B. Donepezil, C. Levodopa with carbidopa, D. Sertraline at bedtime. Take a second. Which answer would you pick? The correct answer is B. Donepezil. B is correct because cholinesterase inhibitors such as donepezil, rivastigmine, and galantamine are first line for mild to moderate Alzheimer disease. They preserve acetylcholine in the synapse to support memory and cognitive function. A is wrong because memantine is an N-methyl D aspartate receptor antagonist used in moderate to severe disease, often added to a cholinesterase inhibitor. It is not the starting drug for mild disease. C is wrong because levodopa with carbidopa is used for Parkinson's disease to replace dopamine. It does not treat Alzheimer pathology. D is wrong because sertraline can be used for depression that often accompanies dementia, but it does not treat the underlying cognitive decline. Alzheimer disease is the most common cause of dementia, accounting for about 2/3 of cases. It is a progressive brain disorder driven by the buildup of amyloid plaques and tau neurofibrillary tangles, leading to neuronal death and widespread atrophy. The hallmark lesions are extracellular amyloid plaques and intracellular tau-containing neurofibrillary tangles. The cholinergic system is damaged early, which is precisely why it becomes the pharmacologic target. Cholinesterase inhibitors such as donepezil, rivastigmine, and galantamine block the enzyme that normally clears acetylcholine from the synapse. This allows acetylcholine to accumulate, prolonging the cholinergic signal among the neurons that still survive. For mild to moderate Alzheimer disease, the first-line choice is a cholinesterase inhibitor. Dampezil is most commonly used on exams. Memantina, an NMDA receptor antagonist, is reserved for moderate to severe stages, often added on top of a cholinesterase inhibitor. When a stem describes insidious memory loss, temporal atrophy, and mild disease severity, a cholinesterase inhibitor is the answer. Memantine comes later, and drugs like levodopa or sertraline address entirely different conditions. Question 27. A 30-year-old woman presents with intermittent vision loss, paresthesias in both legs, and persistent fatigue. Magnetic resonance imaging shows multiple white matter lesions in the brain and spinal cord. Lumbar puncture reveals oligoclonal bands. Which diagnosis best matches these findings? Your options are A. Guillain-Barré syndrome, B. Myasthenia gravis, C. Amyotrophic lateral sclerosis, D. Multiple sclerosis. Before I reveal it, which one do you think is right? The correct answer is D. Multiple sclerosis. D is correct because multiple sclerosis is a demyelinating disease that damages the myelin sheath in the brain, optic nerves, and spinal cord, producing relapsing visual, sensory, and motor symptoms. White matter lesions on imaging and oligoclonal bands in cerebrospinal fluid are characteristic. A is wrong because Guillain-Barré syndrome produces ascending symmetrical weakness, often after an infection, with elevated cerebrospinal fluid protein and no white matter lesions on brain imaging. B is wrong because myasthenia gravis causes fluctuating muscle weakness that worsens with activity and has no relationship to white matter demyelination. C is wrong because amyotrophic lateral sclerosis affects upper and lower motor neurons, producing weakness with fasciculations, but does not cause optic neuritis or white matter lesions. Multiple sclerosis is an autoimmune disease in which the immune system destroys the myelin sheath, insulating nerve fibers in the brain, optic nerves, and spinal cord. This demyelination slows or blocks nerve conduction, producing the hallmark relapsing or progressive neurologic deficits. Autoreactive T lymphocytes cross the blood-brain barrier, recognize myelin antigens, and orchestrate inflammatory destruction of the insulating sheath. Over time, demyelination accumulates and axonal damage follows, explaining why deficits become permanent as the disease progresses. Diagnosis requires demonstrating lesions disseminated in both space and time. MRI reveals characteristic white matter lesions, and lumbar puncture often shows oligoclonal bands indicating intrathecal antibody synthesis. The disease disproportionately affects young women of European ancestry. Each major neurologic mimic lives in a different anatomic compartment. Guillain-Barré is acute peripheral demyelination with ascending paralysis. Myasthenia gravis targets the neuromuscular junction with fatigable weakness. ALS destroys upper and lower motor neurons with progressive weakness and fasciculations. When an exam stem combines a young woman with optic neuritis, sensory deficits, fatigue, and white matter lesions on MRI occurring weeks or months apart, multiple sclerosis is the answer. Dissemination in time and space is the defining principle. Question 28. A patient suspected of having myasthenia gravis is being evaluated using the edrophonium test. The clinician administers a test dose and observes the patient closely for the diagnostic response. Which observation supports the diagnosis of myasthenia gravis? Your options are A. Brief improvement in muscle strength following edrophonium administration, B. Worsening weakness with progressive bulbar paralysis after the dose, C. No measurable change in symptoms at any time. D. Sudden onset of generalized seizure activity within minutes. What's your answer? Commit to one before I continue. The correct answer is A. Brief improvement in muscle strength following edrophonium administration. A is correct because edrophonium briefly inhibits the breakdown of acetylcholine, increasing its concentration at the neuromuscular junction. In myasthenia gravis, this produces a transient and dramatic improvement in muscle strength. Confirming the diagnosis? B is wrong because worsening weakness after the dose suggests cholinergic crisis, not myasthenic crisis. The clinician keeps atropine ready for that scenario. C is wrong because no change at all argues against a neuromuscular junction problem responsive to acetylcholine increase. The diagnostic point is the transient improvement. D is wrong because seizure activity is not an expected response and would point to a different neurologic problem rather than confirming myasthenia gravis. Myasthenia gravis is a chronic autoimmune disease where antibodies attack nicotinic acetylcholine receptors at the neuromuscular junction. Understanding the underlying mechanism helps explain every feature of this condition. Normally, acetylcholine crosses a synaptic cleft and binds nicotinic receptors to trigger contraction. In myasthenia gravis, autoantibodies block or destroy those receptors, so repeated nerve signals produce progressively weaker and weaker responses, the hallmark of fatigable weakness. Disease typically begins in the ocular muscles, causing drooping eyelids and double vision that worsen toward evening. It can progress to bulbar muscles affecting swallowing and speech, and in myasthenic crisis, respiratory muscles are compromised, requiring mechanical ventilation. Diagnosis combines antibody testing, pharmacologic challenge, and electrophysiology. The edrophonium test works by briefly inhibiting acetylcholine esterase, raising acetylcholine levels at the synapse and producing a short-lived but telling improvement in strength. CT imaging of the chest is essential because stomach abnormalities drive the autoimmune process. Distinguishing myasthenia gravis from lookalikes is high yield. Lambert-Eaton syndrome is presynaptic and linked to small cell lung cancer, with strength that paradoxically improves with repeated effort. Multiple sclerosis involves central demyelination, while ALS combines upper and lower motor neuron findings. Neither causes fatigable weakness that responds to edrophonium. Question 29. A 60-year-old patient presents with a wide-based unsteady gait, slurred speech, intention tremor, and difficulty performing rapid alternating movements. Imaging shows atrophy of a specific brain region responsible for coordinating voluntary movement. Which structure is most likely damaged? Your options are A. Frontal motor cortex, B. Basal ganglia, C. Cerebellum, D. Brainstem nucleus alone. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is C. Cerebellum. C is correct because ataxia is the clinical hallmark of cerebellar dysfunction. The cerebellum coordinates voluntary movement, balance, and speech, so damage produces wide-based gait, dysarthria, intention tremor, and dysmetria. A is wrong because frontal motor cortex injury causes contralateral weakness or paralysis rather than the coordination problems described. Strength, not coordination, is the affected domain. B is wrong because basal ganglia damage produces movement disorders such as Parkinsonism or chorea, not the cerebellar pattern of ataxia. D is wrong because isolated brainstem injury would typically produce cranial nerve deficits, altered consciousness, or specific syndromes rather than the pure cerebellar picture described. Ataxia is a syndrome of incoordination caused by damage to the cerebellum or its connecting pathways. Understanding why the cerebellum produces these specific signs helps localize the lesion and distinguish it from other movement disorders. The cerebellum coordinates voluntary movement across multiple systems simultaneously. When it fails, patients walk with a wide base, slur their words, overshoot targets, and cannot perform rapid alternating movements, a pattern that often resembles intoxication. The cerebellum works as a real-time error correction engine. It compares the cortex's intended movement against feedback from muscles and joints, then issues continuous corrections. Break this loop and every movement becomes poorly timed, overshooting its target. Localization hinges on recognizing what each region produces when damaged. Only cerebellar injury gives pure incoordination without weakness. Frontal lesions cause weakness. Basal ganglia lesions cause Parkinsonism or chorea, and brainstem lesions add cranial nerve signs. When a stem describes wide-based gait, dysmetria, and slurred speech together, especially without weakness, the cerebellum is the answer. Sensory ataxia improves with visual feedback. Intoxication resolves with sobriety, and stroke is acute. Chronicity and distribution seal the diagnosis. Question 30. A young adult is brought to the emergency department after a high-impact motor vehicle collision in which his head struck the side window. He had a brief loss of consciousness at the scene, regained alertness in transport, and then deteriorated rapidly into coma during evaluation. Computed tomography of the head shows a biconvex hyperdense collection over the right temporal lobe. Which type of intracranial hemorrhage is most consistent with these findings? Your options are A. Subdural hematoma, B. Epidural hematoma, C. Intracerebral hematoma, D. Subarachnoid hemorrhage. Which would you go with? Lock it in before the reveal. The correct answer is B. Epidural hematoma. B is correct because an epidural hematoma is classically associated with a lucid interval followed by rapid deterioration as arterial blood from a torn middle meningeal artery accumulates between the skull and dura. The biconvex shape on imaging confirms the diagnosis. A is wrong because a subdural hematoma appears as a crescent-shaped collection that follows the contour of the brain, typically caused by torn bridging veins. The biconvex shape rules this out. C is wrong because intracerebral hematoma occurs within the brain parenchyma rather than in a potential space and does not produce a biconvex extraaxial appearance on imaging. D is wrong because subarachnoid hemorrhage shows blood layering in the basal cisterns and along sulci rather than a focal biconvex collection. Epidural hematoma is one of the most time-critical diagnoses in emergency medicine. Understanding its anatomy, mechanism, and classic presentation helps you recognize it instantly and act before the window closes. The hallmark presentation unfolds in 3 stages. An initial impact causes brief loss of consciousness from concussion. As the patient recovers, arterial bleeding continues silently in the epidural space. Once the hematoma reaches a critical volume, intracranial pressure rises and the patient deteriorates rapidly, often with ipsilateral pupillary dilation and contralateral hemiparesis. On CT, epidural hematoma appears as a biconvex hyperdense collection that does not cross suture lines, reflecting its arterial source under high pressure. Subdural hematoma, caused by torn bridging veins, forms a crescent shape that follows the brain contour and can cross sutures. Keeping these 4 hemorrhage types distinct is essential. Epidural is arterial and rapidly expanding. Subdural is venous and more common in older or anticoagulated patients. Intracerebral hemorrhage sits within the brain parenchyma, often from hypertension. Subarachnoid hemorrhage presents with thunderclap headache from a ruptured aneurysm. When a trauma patient has a lucid interval followed by rapid deterioration, Think epidural hematoma until proven otherwise. Emergent CT confirmation and surgical evacuation are the standard of care. Early intervention leads to excellent neurologic outcomes. Question 31. A patient with chronic schizophrenia has been on long-term haloperidol therapy and now exhibits irregular involuntary jerky movements of the lower face, lip smacking, and writhing finger movements that the patient cannot control. Which adverse effect of first-generation antipsychotic therapy do these findings represent? Your options are akathisia, B. acute dystonia, C. drug-induced Parkinsonism, D. tardive dyskinesia. Don't overthink it. Which one feels right? The correct answer is D. Tardive dyskinesia. D is correct because tardive dyskinesia is a late-onset extrapyramidal syndrome that develops after months to years of first-generation antipsychotic exposure. It is characterized by repetitive, involuntary jerky movements of the face, mouth, and distal extremities that often persist after the drug is stopped. A is wrong because akathisia presents as motor restlessness and an inability to remain still, rather than discrete, involuntary movements of the face. The phenomenology is distinctly different. B is wrong because acute dystonia produces sustained muscle contractions early in treatment, often involving the neck, jaw, or eyes, and resolves quickly with anticholinergics. C is wrong because drug-induced Parkinsonism causes rigidity, bradykinesia, and tremor at rest rather than the writhing involuntary movements described. Tardive dyskinesia is a delayed onset movement disorder caused by long-term exposure to dopamine receptor antagonists, particularly first-generation antipsychotics. Understanding why it developed and why it persists is the key to recognizing and preventing it. The mechanism centers on postsynaptic dopamine receptor supersensitivity. Chronic blockade causes the basal ganglia to upregulate receptor density and sensitivity. When dopamine signaling resumes or fluctuates, those supersensitive receptors fire excessively, producing the characteristic involuntary movements. Clinically, tardive dyskinesia targets the lower face, tongue, lips, and distal extremities. Patients are often unaware of the movement. Family members notice first. Crucially, stopping the offending drug does not reliably resolve the condition, which is why early recognition matters so much. Separating the four extrapyramidal syndromes comes down to onset and phenomenology. Acute dystonia brings sustained muscle contractions early. Akathisia is restlessness within days to weeks. Drug-induced Parkinsonism adds bradykinesia and rigidity over weeks to months. Tardive dyskinesia arrives last, irregular and jerky, and may never fully resolve. Because the receptor changes in tardive dyskinesia can become permanent, prevention through careful prescribing and regular monitoring is essential. If it develops, switching to a second-generation agent or adding a VMAT2 inhibitor like valbenazine can help manage symptoms. Question 32. A patient is newly diagnosed with major depressive disorder and is otherwise healthy with no medication, allergies, and no contraindications. The provider plans first-line pharmacologic therapy. Which medication is the most appropriate initial choice? Your options are A. phenelzine, B. sertraline, C. amitriptyline, D. lithium carbonate. Got a guess? Lock it in. The correct answer is B. sertraline. B is correct because selective serotonin reuptake inhibitors such as sertraline are first-line therapy for major depression because of their tolerability, safety in overdose, and efficacy The drug class is the standard starting point unless contraindicated. A is wrong because phenelzine is a monoamine oxidase inhibitor used as a later-line agent due to dietary and drug interactions, including the risk of hypertensive crisis with Tiramount. C is wrong because amitriptyline is a tricyclic antidepressant effective for depression, but reserved for select cases due to anticholinergic effects, sedation, and cardiac toxicity in overdose. D is wrong because lithium is a mood stabilizer used primarily in bipolar disorder, not as first-line therapy for unipolar depression. Major depressive disorder requires at least 2 weeks of depressed mood or anhedonia, plus additional symptoms like sleep changes, fatigue, and worthlessness. The first-line pharmacologic treatment is a selective serotonin reuptake inhibitor. The major SSRIs share 3 key advantages: tolerability, safety and overdose, and proven efficacy. Remember that mood improvement takes 2 to 4 weeks, and maximum benefit may not appear until 6 to 8 weeks of full dosing. SSRIs block the serotonin transporter on the presynaptic neuron, preventing serotonin from being pulled back out of the synapse. This raises synaptic serotonin within hours, but the actual antidepressant effect takes weeks, pointing to downstream receptor changes and neuroplasticity as the true therapeutic mechanism. When the exam describes a new depression diagnosis without bipolar history or contraindications, choose an SSRI. Other classes fill specific niches: SNRIs when pain or fatigue dominates, TCAs and MAOEs for refractory cases, and bupropion when sexual side effects or smoking cessation are concerns. Watch for signal phrases like depressed mood, anhedonia, sleep or weight changes, and 2 or more weeks duration. That combination points directly to an SSRI, and avoid stopping one abruptly, as discontinuation syndrome can follow. Question 33. An adult patient describes excessive worry about everyday matters such as work, finances, and family safety occurring on most days for the past 9 months. The patient reports muscle tension, difficulty sleeping, irritability, easy fatigue, and impaired concentration. Which finding meets criteria for generalized anxiety disorder? Your options are: A. Excessive worry for 6 months or longer paired with at least 3 associated symptoms. B. 2 weeks of low mood with anhedonia and weight changes. C. Recurrent unexpected panic attacks for at least 1 month. D. 6 weeks of intrusive memories after a single trauma. Which one is it? Pause the video if you need more time. The correct answer is A. Excessive worry for 6 months or longer paired with at least 3 associated symptoms. A is correct because generalized anxiety disorder is diagnosed after at least 6 months of excessive worry that is difficult to control, accompanied by 3 or more of the 6 characteristic symptoms including restlessness, fatigue, irritability, muscle tension, sleep disturbance, and impaired concentration. B is wrong because A. 2-week threshold of low mood and anhedonia describes the time frame for major depressive disorder, not anxiety. C is wrong because 1 month of recurrent unexpected panic attacks describes panic disorder, which is a separate anxiety condition with discrete attacks rather than chronic worry. D is wrong because trauma-related intrusive memories describe post-traumatic stress disorder, with its own time and symptom criteria distinct from generalized anxiety disorder. Generalized anxiety disorder is defined by excessive, hard-to-control worry spanning multiple areas of life. Understanding its precise diagnostic criteria is what separates it from other anxiety conditions. The 6-month threshold was chosen to confirm worry as a stable trait rather than a fleeting stress response. Requiring at least 3 accompanying symptoms ensures there is, meaningful functional impairment beyond mere self-reported worry. Each anxiety disorder has a distinct signature. GAD is broad and chronic. Panic disorder centers on unexpected attacks. Social anxiety is tied to evaluation by others. PTSD is anchored to a specific traumatic event. Unlike fear with a single clear trigger, GAD involves a threat detection system that stays persistently activated across multiple domains, reflecting altered amygdala function and reduced prefrontal regulation of emotional responses. When an exam stem combines months of wide-ranging worry with restlessness, tension, fatigue, or sleep trouble, generalized anxiety disorder is the diagnosis that fits. Duration, breadth, and associated symptoms are the deciding factors. Question 34. A combat veteran with post-traumatic stress disorder reports recurrent nightmares of his deployment that wake him several times each night and severely affect his daytime functioning. He has been stable on a serotonin reuptake inhibitor for daytime symptoms, but the nightmares persist. Which medication addresses trauma-related nightmares specifically? Your options are A. Sertraline at bedtime, B. Hydroxyzine taken as needed, C. Prazosin at bedtime, D. Lithium carbonate. Take a second. Which answer would you pick? The correct answer is C. Prazosin at bedtime. C is correct because prazosin is an alpha-1 adrenergic antagonist used to suppress trauma-related nightmares in post-traumatic stress disorder. It reduces sympathetic activation during sleep and has the strongest evidence for this specific symptom. A is wrong because sertraline addresses general post-traumatic symptoms during the day. Adding more at bedtime does not specifically target nightmares and may worsen sleep. B is wrong because hydroxyzine is an antihistamine used for general anxiety and insomnia, but not specifically targeted to combat nightmares of post-traumatic stress disorder. D is wrong because lithium is a mood stabilizer for bipolar disorder. It has no role in treating trauma nightmares. PTSD is defined by 4 symptom clusters: intrusions, avoidance, negative mood and cognition, and hyperarousal. Trauma-related nightmares fall into the intrusion cluster and are notoriously resistant to standard antidepressant therapy. Prazosin is an alpha-1 receptor antagonist originally developed to lower blood pressure. In PTSD, it works centrally by dampening the surge of noradrenergic activity during REM sleep that drives trauma nightmares, making it uniquely effective where SSRIs fall short. During REM sleep, trauma survivors exhibit pathologically elevated sympathetic tone. Prazosin blocks alpha-1 receptors in central pathways, quieting this activity and allowing normal sleep architecture to re-emerge. Peripherally, the same blockade causes vasodilation, or lactamate, the source of orthostatic hypertension, its primary side effect. Each medication occupies a distinct niche. SSRIs are first line for daytime PTSD symptoms. Prazosin is added specifically for trauma nightmares. Trazodone addresses general insomnia without nightmare-specific benefit. Benzodiazepines are generally avoided due to dependence risk and cognitive worsening over time. When an exam stem describes a trauma survivor with persistent nightmares despite an adequate antidepressant trial, prazosin is the targeted answer. Recognize the signal: recurrent nightmares, hyperarousal, and sleep disruption pointing to noradrenergic overactivity at night. Question 35. A patient with treatment-resistant depression is being started on phenelzine. The nurse provides dietary teaching to prevent a potentially life-threatening hypertensive crisis from a known food-drug interaction. Which dietary instruction is the priority? Your options are A. Avoid grapefruit juice and saint, John Wort. B. Avoid aged cheese, cured meats and red wine. C. Avoid leafy greens that are high in vitamin K. D. Avoid all dairy products and calcium supplements. Before I reveal it, which one do you think is right? The correct answer is B. Avoid aged cheese, cured meats, and red wine. B is correct because monoamine oxidase inhibitors such as phenelzine block the enzyme that metabolizes tyramine, a compound concentrated in aged, cured, fermented, and smoked foods. Eating tyramine-rich foods while on the drug can trigger a sudden severe hypertensive crisis. A is wrong because grapefruit and St. John wort have important interactions with other drugs but are not the dietary issue tied to hypertensive crisis with monoamine oxidase inhibitors. C is wrong because vitamin K is the central concern for warfarin, not for monoamine oxidase inhibitors. The mechanism is unrelated. D is wrong because dairy and calcium supplements do not interact significantly with phenelzine. Aged cheeses are an issue, but not all dairy. Monoamine oxidase inhibitors are powerful antidepressants, but they carry a unique and potentially fatal dietary risk. Understanding the mechanism behind this risk is essential for safe prescribing and patient education. Normally, monoamine oxidase in the gut wall destroys dietary tyramine before it reaches the bloodstream. When MAOs block this enzyme, tyramine floods into circulation, triggering a massive release of stored norepinephrine and producing a sudden, severe hypertensive crisis within 15 to 90 minutes. Foods that are aged, fermented, smoked, or cured carry the highest tyramine loads. Patients on phenelzine or other irreversible MAOIs must avoid aged cheeses, cured meats like salami, red wine, certain beers, soy sauce, and sauerkraut. MAOs carry two distinct interaction dangers. Dietary tyramine causes hypertensive crisis, while combining an MAOI with any serotonergic drug risks serotonin syndrome, a separate emergency marked by hypothermia, agitation, and autonomic instability. A careful washout period is required before switching agents. When you see MAOI on an exam, think tyramine restriction and hypertensive crisis first, and always recognize the second danger of serotonin syndrome when any serotonergic drug is combined. Question 36. A child with sickle cell disease is brought to the emergency department in acute vaso-occlusive crisis with severe extremity pain, fever, and dehydration. The team plans the initial sequence of priority interventions. Which order of treatment is correct? Your options are A. Begin oral folic acid and discharge home with follow-up next day. B. Transfuse 2 units of packed red cells before any fluid management. C. Initiate hydroxyurea infusion as the first-line crisis therapy. D. Initiate intravenous fluids first, then intravenous analgesia and supplemental oxygen. What's your answer? Commit to one before I continue. The correct answer is D. Initiate intravenous fluids first, then intravenous analgesia and supplemental oxygen. D is correct because the priority sequence in vaso-occlusive crisis is hydration first to expand intravascular volume and improve red cell flow, followed by intravenous opioid analgesia and supplemental oxygen. Fluids correct the dehydration that often triggers and sustains the crisis. A is wrong because discharge with oral folic acid is appropriate maintenance, not crisis management. The patient needs hospital-level intervention now. B is wrong because transfusion is not the first step in routine vaso-occlusive crisis. It is reserved for specific situations such as splenic sequestration, acute chest syndrome, or stroke. C is wrong because hydroxyurea is a long-term oral preventive medication, not a crisis treatment. It works by reducing future episodes, not relieving current pain. Vaso-occlusive crisis is the most common acute complication of sickle cell disease. Understanding why it happens and how to treat it in the right order is essential for both the exam and clinical care. Hemoglobin S polymerizes under low oxygen and high osmolarity, distorting red cells into rigid sickle shapes that obstruct capillaries. The resulting local hypoxia and acidosis worsen sickling in a self-reinforcing loop, generating ischemia and severe pain. Hydration and oxygenation are the interventions that break the cycle. Management follows a clear evidence-based order. Intravenous fluids come first because dehydration is both a trigger and a perpetuating factor. Restoring volume improves microcirculatory flow and reduces ongoing sickling. Opioid analgesia follows once access is established and supplemental oxygen is added to address hypoxemia. Not all sickle cell crises are managed the same way. Vaso-occlusive crisis is treated with hydration, opioids, and oxygen. Routine transfusion is not indicated here. Acute chest syndrome, splenic sequestration, and aplastic crisis each have distinct presentations and may require transfusion as a priority intervention. When the exam describes sickle cell disease with severe pain, fever, and dehydration, the priority sequence is intravenous fluids first, then opioid analgesia, then supplemental oxygen. Hydroxyurea and transfusion are not standard acute vaso-occlusive crisis treatments. Question 37. A 6-year-old child of Greek heritage presents with severe microcytic anemia that has not responded to oral iron supplementation. Hemoglobin electrophoresis reveals reduced production of beta-globin chains, and family history reveals 2 siblings with similar findings. Which diagnosis best fits this presentation? Your options are A. Glucose 6-phosphate dehydrogenase deficiency, B. Sickle cell anemia, C. Beta thalassemia, D. Hereditary spherocytosis. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is C. Beta thalassemia. C is correct because beta thalassemia is an inherited disorder of reduced or absent beta globin chain production, leading to severe microcytic anemia that is not corrected by iron. It is most common in Mediterranean, Middle Eastern, African, Chinese, and South Asian populations. A is wrong because glucose 6-phosphate dehydrogenase deficiency causes episodic hemolytic anemia triggered by oxidative stress, not chronic microcytic anemia from globin chain underproduction. B is wrong because sickle cell anemia is a hemoglobinopathy producing sickled red cells and vaso-occlusive crises with normocytic rather than markedly microcytic anemia. D is wrong because hereditary spherocytosis causes hemolytic anemia from a red cell membrane defect, with spherocytes on smear and normal mean corpuscular volume. Beta thalassemia is an inherited disorder where beta globin chain production is reduced or absent, causing chronic microcytic anemia. The severity depends on how many gene copies are affected, ranging from clinically silent to transfusion-dependent disease. The spectrum runs from thalassemia minor, which is usually asymptomatic, through thalassemia major, which requires lifelong transfusions. The specific mutation and whether one or both gene copies are involved drives this range. When beta chains are underproduced, free alpha chains accumulate and precipitate inside developing red cells, destroying them before they leave the marrow. This ineffective erythropoiesis triggers massive marrow expansion and increased iron absorption, producing the skeletal changes and iron overload seen in severe disease. Each anemia has a distinct mechanism. Beta thalassemia and iron deficiency both cause microcytic anemia, but iron stores are normal or elevated in thalassemia, and iron supplementation produces no improvement. Sickle cell and hereditary spherocytosis are normocytic hemolytic anemias with their own clinical signatures. When a child of Mediterranean, Middle Eastern, African, or Asian descent has severe microcytic anemia that does not respond to iron. Thalassemia should top the differential. Hemoglobin electrophoresis showing reduced hemoglobin A with elevated A2 and fetal hemoglobin confirms the diagnosis. Question 38. A patient with glucose 6-phosphate dehydrogenase deficiency asked the nurse for a teaching summary of foods and medications that should be avoided to prevent hemolysis. Which list is correct? Your options are A. Fava beans, sulfur antibiotics, and aspirin. B. Citrus fruits, vitamin D supplements, and shellfish. C. Lean red meat, poultry, and iron-fortified cereal. D. Whole grain breads, legumes other than fava, and brown rice. Which would you go with? Lock it in before the reveal. The correct answer is A. Fava beans, sulfur antibiotics, and aspirin. A is correct because fava beans, sulfur antibiotics, antimalarials such as chloroquine, methylene blue, aspirin, and high-dose vitamin C all trigger oxidative red cell destruction in glucose 6-phosphate dehydrogenase deficiency. Avoiding these triggers is the central self-management point. B is wrong because citrus, vitamin D, and shellfish are not common hemolysis triggers in this disorder. The teaching list focuses on oxidative stresses. C is wrong because lean red meat, poultry, and iron-fortified cereals are healthy and do not trigger hemolysis. Avoiding them would worsen overall nutrition. D is wrong because whole grains, brown rice, and most legumes are safe. Only fava beans specifically need to be avoided. Glucose 6-phosphate dehydrogenase deficiency is the most common enzyme deficiency in humans, affecting over 400 million people worldwide. It follows an X-linked recessive pattern, so males are predominantly affected, and it clusters in populations from Africa, the Mediterranean, the Middle East, and Asia. Normally, G6PD drives production of NADPH, which keeps glutathione in its reduced active form. Reduced glutathione neutralizes reactive oxygen species inside red blood cells. Without enough G6PD, oxidative stress accumulates, damages hemoglobin interhinds bodies, and triggers premature destruction of red cells. Patients must learn to avoid a specific set of oxidative triggers for life. The highest yield list includes fava beans, primaquine and chloroquine, sulfur antibiotics, naphthalene mothballs, methylene blue, and high-dose vitamin C. Distractor items like citrus fruits or whole grains are not true triggers. On blood smear, bite cells and Heinz bodies are the hallmark findings. Lactate dehydrogenase and indirect bilirubin rise during the hemolytic episode. Crucially, the hemolysis is self-limited once the trigger is removed. An enzyme assay should be performed weeks later when red cell levels have normalized. When an exam stem combines male sex, African or Mediterranean ancestry, sudden jaundice after a specific exposure, and bite cells with Heinz bodies, GCAD deficiency fits best. Separating it from sickle cell disease, hereditary spherocytosis, and autoimmune hemolytic anemia comes down to identifying that characteristic trigger-driven episodic pattern. Question 39. Parents of a young boy with red-green color blindness are asking about the inheritance pattern so they can counsel future family members. Which explanation correctly describes how this trait is most commonly inherited? Your options are A. Autosomal dominant from either parent. B. X-linked, transmitted from mother to son. C. Autosomal recessive, requiring both parents to be carriers. D. Mitochondrial inheritance from father to all children. Don't overthink it. Which one feels right? The correct answer is B. X-linked, transmitted from mother to son. B is correct because red-green color blindness results from mutations in the OPN1MW gene located on the X chromosome. Because boys have only one X chromosome and inherit it from their mother, the trait is passed predominantly from carrier mothers to affected sons. A is wrong because autosomal dominant inheritance would affect males and females equally and would not explain the male predominance seen with this trait. C is wrong because autosomal recessive inheritance requires two altered copies and shows equal sex distribution. This pattern does not fit X-linked color blindness. D is wrong because mitochondrial inheritance comes from the mother, not the father, and would affect all offspring of an affected mother. It is not the mechanism for color vision genes. Color blindness is a genetic condition rooted in how cone cells in the retina detect wavelengths of light. Understanding its inheritance pattern requires knowing where the responsible gene lives in the genome. The retina contains 3 cone types sensitive to short, medium, and long wavelengths. The brain combines their signals to produce full color perception. When the medium or long wavelength cone pigment is altered or absent, red and green become indistinguishable. Because the OPN1W gene sits on the X chromosome, males who inherit one affected X from their carrier mother have no second copy to compensate. Females need both X chromosomes affected to express the trait, which is why red-green color blindness overwhelmingly affects males. Not all color vision disorders share the same pattern. Blue-yellow color blindness is autosomal and affects both sexes equally, while achromatopsia is a rare autosomal recessive condition causing total color blindness. Acquired color vision loss from optic neuritis or medications follows no inheritance pattern at all. When a clinical stem describes red-green color confusion running through the maternal line and affecting mostly males, X-linked recessive inheritance is the answer. The trait passes from carrier mother to affected son, not through autosomal or mitochondrial routes. Question 40. A 6-month-old infant of Ashkenazi Jewish heritage is brought in for evaluation of progressive loss of motor skills, exaggerated startle response, and poor head control. Funduscopic examination reveals a cherry red spot on the macula. Which inherited disorder best fits this picture? Your options are A. Sickle cell anemia, B. Beta thalassemia, C. Tay-Sachs disease, D. Hutchinson-Gilford progeria syndrome. Got a guess? Lock it in. The correct answer is C. Tay-Sachs disease. C is correct because Tay-Sachs disease is a lipid storage disorder caused by deficiency of the enzyme that breaks down a specific fatty substance, leading to toxic buildup in nerve cells. It is more common in Ashkenazi Jewish infants and presents with developmental regression, exaggerated startle, and the classic cherry red macular spot. A is wrong because sickle cell anemia is a hemoglobinopathy that causes vasoocclusion and hemolysis, not progressive neurodegeneration with a cherry red macular spot. B is wrong because beta thalassemia is a chronic hemoglobin disorder presenting with anemia and growth delay, not the neurologic regression described. D is wrong because Hutchinson-Gilford progeria causes premature aging features such as alopecia, growth failure, and cardiovascular disease, not a cherry red macular spot or the specific neurologic presentation. Tay-Sachs disease is an autosomal recessive lysosomal storage disorder caused by deficiency of hexosaminidase A, an enzyme that normally breaks down GM2 ganglioside in neurons. Without hexosaminidase A, GM2 ganglioside accumulates inside neuronal lysosomes. This toxic buildup disrupts cellular function and ultimately destroys neurons, producing progressive neurodegeneration beginning in infancy. The hallmark presentation combines progressive loss of motor milestones, an exaggerated startle response to sound, and a cherry red macular spot on fundoscopic exam, the last caused by GM2 accumulation in retinal ganglion cells, making the underlying choroid stand out. Tay-Sachs is distinguished from related storage diseases by its specific enzyme defect. Sandhoff disease involves both hexosaminidase A and B. Niemann-Pick involves sphingomyelinase deficiency with hepatosplenomegaly. Krabbe disease involves galactocerebrosidase deficiency. When an exam stem combines Ashkenazi Jewish heritage, infantile neurologic regression, and a cherry red macular spot, Tay-Sachs disease is the diagnosis. Carrier screening has substantially reduced incidence in at-risk populations. Question 41. A 4-year-old child is brought in with a 3-day history of right ear pain, fever to 102.1 F, and irritability. Otoscopic examination shows a bulging erythematous tympanic membrane with poor mobility on insufflation. The child has no penicillin allergy and no recent antibiotic exposure. Which medication is the appropriate first-line therapy? Your options are A. Oral amoxicillin, B. Topical neomycin and polymyxin drops, C. Oral azithromycin, D. Intravenous vancomycin. Which one is it? Pause the video if you need more time. The correct answer is A. Oral amoxicillin. A is correct because acute otitis media in pediatric patients is most often caused by Streptococcus pneumonia, and oral amoxicillin remains the first-line antibiotic when treatment is indicated. The dose, duration, and oral route fit standard guidelines for an otherwise healthy child. B is wrong because topical drops do not penetrate the middle ear well and are used for otitis externa, not otitis media. They cannot reach the site of infection behind the tympanic membrane. C is wrong because macrolides such as azithromycin are reserved for patients with documented penicillin allergy. They are not first line for an unallergic child. D is wrong because intravenous vancomycin is used for serious resistant infections such as meningitis or methicillin-resistant Staphylococcus aureus. It is far too broad and aggressive for a routine middle ear infection. Acute otitis media is among the most common bacterial infections in young children, developing when fluid trapped behind the tympanic membrane becomes infected, typically following a viral upper respiratory illness that disrupts eustachian tube drainage. Otoscopy is central to diagnosis. A bulging, red eardrum with reduced movement on insufflation confirms fluid under pressure in the middle ear space. The 3 dominant pathogens are Streptococcus pneumonia, non-typable Haemophilus influenzae, and Moraxella catarrhalis. High-dose amoxicillin covers them effectively and remains first line. When beta-lactamase-producing strains cause treatment failure, amoxicillin clavulanate becomes the second-line choice. Amoxicillin is a beta-lactam that inhibits cell wall synthesis by binding penicillin-binding proteins, blocking cross-linking of peptidoglycan strands until the weakened bacterial wall ruptures. When a young child presents with classic otitis media findings and no penicillin allergy, oral high-dose amoxicillin is the correct first-line answer. Reserve macrolides for true penicillin allergy and amoxicillin clavulanate for treatment failure or beta-lactamase coverage. Question 42. A 6-year-old previously healthy girl presents with dysuria, urinary frequency, and lower abdominal pain. She is afebrile, not vomiting, and has no flank tenderness. Urinalysis shows leukocyte esterase, nitrites, and pyuria. Which medication is the recommended first-line therapy for uncomplicated pediatric urinary tract infection? Your options are nitrofurantoin, B. levofloxacin, C. amoxicillin alone, D. trimethoprim sulfamethoxazole. Take a second. Which answer would you pick? The correct answer is D. Trimethoprim sulfamethoxazole. D is correct because trimethoprim sulfamethoxazole is the recommended initial treatment for uncomplicated lower urinary tract infection in pediatric patients with no contraindications. It covers the most common pathogens including Escherichia coli with reliable oral dosing. A is wrong because nitrofurantoin is used in adolescents and adults but is generally avoided in younger children for cystitis as a first choice and does not cover pyelonephritis adequately. B is wrong because fluoroquinolones such as levofloxacin are avoided in children when alternatives exist due to musculoskeletal and tendon concerns. C is wrong because amoxicillin alone has high resistance rates against community Escherichia coli and is no longer recommended as monotherapy for pediatric urinary tract infection. Urinary tract infections are among the most common bacterial infections in children, and choosing the right antibiotic matters. Untreated or undertreated UTI can progress to pyelonephritis and cause permanent renal scarring. Trimethoprim sulfamethoxazole works by sequential blockade of bacterial folate synthesis. Sulfamethoxazole inhibits dihydropteroate synthase while trimethoprim inhibits dihydrofolate reductase. Blocking two steps in the same essential pathway achieves bactericidal activity, even though each drug alone would be only bacteriostatic. Escherichia coli dominates pediatric community-acquired UTI. Knowing the pathogen distribution helps explain why TMP-SMX, which covers most community E. coli, remains a rational empiric first choice in many regions. When choosing oral therapy, TMP-SMX leads when local resistance permits. Amoxicillin alone is no longer first line due to high resistance rates. Nitrofurantoin is reserved for adolescents and adults. Fluoroquinolones are avoided in children because of musculoskeletal and tendon concerns. The key clinical skill is matching treatment intensity to disease severity. An afebrile, school-aged child with classic lower tract symptoms and no vomiting gets oral TMP-SMX. A toxic or vomiting child with suspected pyelonephritis needs parenteral therapy. Always reassess once culture and sensitivity results return. Question 43. A child with active varicella has fever and skin pain from a widespread vesicular rash. The mother asks the nurse which over-the-counter analgesic and antipyretic is safe to give. Which response is correct? Your options are A. Aspirin every 6 hours around the clock. B. Acetaminophen at weight-appropriate doses. C. Ibuprofen every 4 to 6 hours as needed. D. Naproxen twice daily until fever resolves. Before I reveal it, which one do you think is right? The correct answer is B. Acetaminophen at weight-appropriate doses. B is correct because acetaminophen is the recommended antipyretic and analgesic for children with varicella. It controls fever and pain without the risk tied to other agents. A is wrong because aspirin must be avoided in children with viral illness because of the risk of Reye syndrome, a life-threatening encephalopathy and liver injury. C is wrong because ibuprofen worsens varicella skin lesions and increases the risk of severe soft tissue infection. It is specifically not recommended for chickenpox. D is wrong because naproxen carries similar concerns to ibuprofen as a non-steroidal agent and is not considered safe for varicella analgesia. When a child has chickenpox, the choice of fever and pain reliever is not just a preference. It's a patient safety issue with serious, well-documented consequences. Aspirin triggers Reye syndrome, a rare but devastating combination of brain and liver failure first linked to pediatric viral illness in the 1970s. Ibuprofen, meanwhile, appears to impair neutrophil function during varicella opening the door to severe soft tissue infections like necrotizing fasciitis from group A streptococcus. The key distinction is that each unsafe drug carries a different and specific mechanism of harm. Aspirin causes Reye syndrome through a metabolic pathway during viral illness, while ibuprofen promotes bacterial superinfection by blunting the immune response at exactly the wrong time. Acetaminophen at weight-appropriate dosing is the safe analgesic and antipyretic of choice. Supportive measures like oatmeal baths, calamine lotion, and trimmed fingernails reduce discomfort and minimize the risk of secondary skin infection from scratching. When the exam describes a child with active chickenpox asking about safe over-the-counter medication, acetaminophen is always the answer. Aspirin means Reye syndrome. Ibuprofen means necrotizing fasciitis risk. Neither belongs in varicella management. Question 44. A 6-week-old breastfed infant develops white patches on the inner cheeks and tongue that do not wipe away easily. The mother also reports cracked, painful nipples that worsen during feedings. Which treatment plan addresses both mother and infant appropriately? Your options are A. Oral acyclovir suspension for the infant. B. Oral amoxicillin for the infant. C. Nystatin oral suspension to the infant mouth and topical antifungal therapy for the mother. D. Topical hydrocortisone cream for the infant and warm saline rinses for the mother. What's your answer? Commit to one before I continue. The correct answer is C. Nystatin oral suspension to the infant mouth and topical antifungal therapy for the mother. C is correct because oral thrush in infants is caused by Candida albicans and is treated with Nystatin oral suspension applied to the mouth several times daily for 10 days. Because Candida moves between mother and infant during breastfeeding, the mother is treated topically at the same time to prevent reinfection. I is wrong because acyclovir is an antiviral used for herpes simplex and varicella infections, not Candida overgrowth. It would have no effect on thrush. B is wrong because amoxicillin is an antibacterial agent that does not treat fungal infection. Antibiotic exposure can actually worsen thrush by disrupting normal flora. D is wrong because hydrocortisone is a steroid used for inflammatory skin conditions and would not address fungal infection. Saline rinses alone do not eradicate Candida. Oral candidiasis, or thrush, is a fungal infection caused by Candida albicans that commonly affects newborns and young infants. Understanding why it recurs and how to break that cycle is the core clinical principle. The hallmark of thrush is white patches that resist wiping, unlike milk residue, which clears easily with a cloth. Lesions may leave a raw base when scraped and can interfere with feeding. The critical insight is that mother and infant reinfect each other. Untreated nipple candidiasis in the mother continuously seeds the infant's mouth and vice versa. Concurrent treatment is the only way to break this cycle. Nystatin oral suspension is applied directly to the infant's mouth after feedings. It stays local because it is poorly absorbed from the gut. The mother applies topical nystatin or miconazole to the nipple after feedings. Both must be treated simultaneously. Distinguishing thrush from its mimics is straightforward. Milk residue wipes off cleanly. Oral herpes produces painful vesicles treated with acyclovir, not antifungals. Leukoplakia is a precancerous adult lesion. When a breastfed infant has persistent white patches that resist wiping and the mother has painful cracked nipples, think thrush and treat both. Question 45. An 8-year-old child presents with a sudden onset sore throat, fever, tender anterior cervical lymphadenopathy, and exudates on the tonsils. A rapid antigen detection test for group A streptococcus is positive and the child has no allergies. Which medication is the appropriate first-line therapy? Your options are A. Acyclovir. B. Azithromycin. C. Vancomycin. D. Amoxicillin. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is D. Amoxicillin. D is correct because streptococcal pharyngitis in pediatric patients is treated with amoxicillin as the first-line oral antibiotic. The drug eradicates the organism, shortens the course of illness, and reduces the risk of acute rheumatic fever. A is wrong because acyclovir is an antiviral used for herpes group viruses. It has no role in bacterial pharyngitis. B is wrong because azithromycin is reserved for patients with documented penicillin allergy. With no allergy noted, amoxicillin is preferred. C is wrong because vancomycin is intravenous therapy for severe gram-positive infections and is not appropriate for routine streptococcal pharyngitis. Streptococcal pharyngitis is caused by group A beta hemolytic Streptococcus pyogenes, and recognizing its classic features is essential for choosing the right treatment. The classic presentation combines sudden sore throat, fever, swollen tender lymph nodes, and tonsillar exudates, notably without cough or coryza. A positive rapid strep test confirms the bacterial cause and justifies targeted antibiotic therapy. Antibiotic therapy shortens illness and limits spread, but the most critical reason to treat is preventing acute rheumatic fever, a post-streptococcal complication that causes permanent cardiac valve damage. This protective window extends up to 9 days after symptom onset. Amoxicillin is the first-line choice in non-allergic children. Reliable coverage, palatable liquid form, and an excellent safety record. Azithromycin is reserved for penicillin-allergic patients. Vancomycin and acyclovir have no role here. 10 days of amoxicillin is the standard course even when symptoms resolve in 2 or 3 days, because shorter courses risk incomplete eradication and loss of rheumatic fever protection. Always counsel families to finish every dose. Question 46. A pregnant woman at 26 weeks gestation is reviewing her vaccination plan for the remainder of pregnancy with her nurse practitioner. The patient asks which vaccine is contraindicated and should be deferred until after delivery. Which response is correct? Your options are: A. The varicella vaccine should be deferred because it is a live virus vaccine. B. The inactivated influenza vaccine should be deferred until the 3rd trimester. C. The Tdap vaccine should be deferred until 1 year postpartum. D. The hepatitis B vaccine is contraindicated and should never be given. Which would you go with? Lock it in before the reveal. The correct answer is A. The varicella vaccine should be deferred because it is a live virus vaccine. A is correct because live virus vaccines, including varicella and measles, mumps, rubella, are contraindicated in pregnancy because of theoretical fetal exposure to the attenuated virus. Varicella vaccination is therefore deferred until after delivery. B is wrong because inactivated influenza vaccine is recommended during any trimester of pregnancy. Deferring it leaves both mother and fetus unprotected. C is wrong because Tdap is recommended between 27 and 36 weeks of gestation in every pregnancy to provide passive immunity to the newborn against pertussis. Deferring it to 1 year postpartum is incorrect. D is wrong because hepatitis B vaccine is an inactivated vaccine and is permitted when the mother is at risk for exposure. It is not contraindicated. The key principle governing vaccination during pregnancy is simple. Inactivated, recombinant, and subunit vaccines are generally safe and often recommended, while live attenuated vaccines are contraindicated due to the theoretical risk of fetal infection. Inactivated influenza is recommended in any trimester and has a strong safety record. Tdap is specifically timed between 27 and 36 weeks to transfer passive antibody protection to the newborn against pertussis during the vulnerable first months of life. The distinction comes down to replication. Live-attenuated vaccines contain weakened virus that can still replicate, creating a theoretical but unacceptable risk of fetal infection. The inactivated injectable influenza vaccine is always preferred over the live nasal spray formulation during pregnancy. Tdap deserves special attention because it is recommended in every single pregnancy, not just the first. Administering it between 27 and 36 weeks maximizes passive antibody transfer to the fetus before delivery, shielding the infant before their own vaccine series can begin. When a pregnant patient asks which vaccine to defer, live attenuated vaccines like varicella and MMR are the answer. Inactivated options are not only permitted, some, like Tdap and influenza, are actively recommended for maternal and fetal protection. Question 47. A patient who has been stable on warfarin for atrial fibrillation is started on doxycycline for a soft tissue infection. The nurse anticipates a significant interaction between these two medications and plans appropriate monitoring. Which interaction is correct? Your options are: A. No clinically significant interaction is expected. B. Doxycycline reduces warfarin effect, so the warfarin dose should be increased. C. Doxycycline enhances the anticoagulant effect of warfarin, and the international normalized ratio should be monitored closely. D. Doxycycline binds to calcium and is unaffected by warfarin. Don't overthink it. Which one feels right? The correct answer is C. Doxycycline enhances the anticoagulant effects of warfarin, and the international normalized ratio should be monitored closely. C is correct because doxycycline enhances the anticoagulant effect of warfarin, raising the international normalized ratio and the risk of bleeding. Close monitoring of the international normalized ratio and dose adjustment of warfarin are required during co-administration. A is wrong because a significant interaction does exist. Failing to monitor would expose the patient to bleeding risk. B is wrong because the interaction increases warfarin effect, not decreases it. Raising the dose during this combination would worsen bleeding risk further. D is wrong because while doxycycline does chelate calcium and other cations affecting absorption, that point does not change its interaction with warfarin metabolism. Anticoagulation effects are clinically significant. When doxycycline is added to a stable warfarin regimen, the anticoagulant effect of warfarin increases. This interaction is multifactorial, and understanding the mechanisms explains why close INR monitoring is essential. Doxycycline suppresses intestinal bacteria that produce vitamin K, reducing a natural brake on anticoagulation. It also displaces warfarin from albumin, raising free drug levels, and may inhibit the cytochrome P450 enzymes, responsible for clearing active warfarin in antiomers. These three mechanisms converge: less vitamin K synthesis, more free drug in plasma, and slower metabolism all push the INR upward beyond the therapeutic range, turning a stable patient into one at meaningful bleeding risk. Not all antibiotics push the INR the same direction. Doxycycline, trimethoprim sulfamethoxazole, and metronidazole all enhance warfarin effects and demand closer monitoring. Rifampin is the key exception. It induces metabolism and reduces warfarin effect, often requiring a dose increase. The practical takeaway is simple. Whenever doxycycline is started in a patient on warfarin, arrange INR monitoring within 3 to 7 days and be ready to reduce the warfarin dose if levels climb. Question 48. A patient of Han Chinese descent is being considered for allopurinol therapy to manage chronic gout and recurrent uric acid kidney stones. Which pharmacogenomic test should be performed before starting therapy to reduce the risk of severe cutaneous adverse reaction. Your options are: A. Recommend tapering allopurinol over 4 weeks regardless of test results. B. Test for the HLA B5801 allele because of the risk of severe cutaneous adverse reactions. C. Confirm HLA-DQ2 status to rule out a celiac flare. D. Avoid allopurinol entirely in all patients of Asian heritage. Got a guess? Lock it in. The correct answer is B. Test for the HLA B5801 allele because of the risk of severe cutaneous adverse reactions. B is correct because the HLA B5801 allele is strongly associated with severe cutaneous adverse reactions to allopurinol, including Stevens-Johnson syndrome and toxic epidermal necrolysis. The allele is most common in Korean, Han Chinese, and Thai patients, and pre-treatment testing is recommended. A is wrong because a taper schedule does not address the underlying genetic risk and does nothing to reduce the chance of a hypersensitivity reaction. C is wrong because HLA-DQ2 status relates to celiac disease risk and is unrelated to allopurinol toxicity. D is wrong because avoiding allopurinol in every Asian patient is overly broad. Most patients can take the drug safely if testing confirms they are negative for the high-risk allele. Allopurinol is a frontline urate-lowering therapy, but in certain patients it carries a rare and potentially fatal risk, SSRIs, severe cutaneous reactions like Stevens-Johnson syndrome and toxic epidermal necrolysis. The key to preventing these catastrophes lies in pharmacogenomics. The HLA-B5801 allele is far more prevalent in patients of Han Chinese, Korean, and Thai descent. Carriers face a dramatically elevated relative risk, higher than nearly any other known pharmacogenomic interaction. Guidelines now recommend testing these populations before starting allopurinol. The proposed mechanism involves allopurinol or its metabolite oxypurinol being presented directly on the HLA-B5801 molecule, which then activates cytotoxic T cells. This immune cascade drives full-thickness epidermal detachment, mucous membrane involvement, and a mortality rate that can exceed 25% in toxic epidermal necrolysis. It's essential not to mix up these tests. Each addresses a specific drug gene pair and is not interchangeable. HLA-B5801 belongs exclusively to the allopurinol risk context in select Asian populations, just as HLA-B1502 belongs to carbamazepine. When you see an allopurinol candidate of Han Chinese, Korean, or Thai ancestry, HLA-B5801 testing is the correct next step. A negative result allows safe initiation. A positive result means choosing an alternative like febuxostat and avoiding a potentially fatal outcome entirely. Question 49. A patient who has been stable on digoxin for heart failure begins taking Saint. John wore it for low mood without notifying the prescriber. Several weeks later, the patient reports worsening dyspnea and edema. Which pharmacokinetic interaction best explains the change in clinical status? Your options are: A. No interaction occurs because St. John wort is an herbal supplement. B. The combination raises digoxin levels and risks toxicity. C. Switching from digoxin to an oral anticoagulant resolves the problem. D. John wort induces cytochrome P453A4 and reduces digoxin therapeutic effect. Which one is it? Pause the video if you need more time. The correct answer is D. John wort induces cytochrome P453A4 and reduces digoxin therapeutic effect. D is correct because St. John wort is a strong inducer of cytochrome P453A4 and the P-glycoprotein transporter. Induction accelerates the metabolism and elimination of many drugs including digoxin, which lowers serum levels and reduces therapeutic benefit, allowing heart failure symptoms to return. A is wrong because although marketed as an herbal supplement saint, John wort has well-documented enzyme-inducing effects on multiple drug pathways. B is wrong because induction of metabolism reduces rather than raises digoxin levels. Toxicity is not the mechanism here. C is wrong because digoxin and oral anticoagulants treat different conditions, and switching them does not address the underlying drug interaction. Heart failure management requires positive inotropy and rate control. So, John's wort is a popular herbal supplement for mild depression, but its interactions with prescription drugs are clinically significant and often overlooked. The core mechanism involves induction of two major drug clearance pathways simultaneously. Hyperforin, the active component, activates the pregnan X receptor, which upregulates transcription of CPJ4 and P-glycoprotein. CYP3Y4 accelerates drug breakdown in the liver and intestine, while P-glycoprotein effluxes substrates back out of cells before they reach systemic circulation. Inducers like Saint John's wort, rifampin, and phenytoin drive drug levels down, risking therapeutic failure. Inhibitors like grapefruit juice and ketoconazole do the opposite, raising levels and risking toxicity. Knowing which direction a substance shifts, the enzyme tells you which clinical danger to anticipate. The classic exam stem shows a stable patient whose condition deteriorates after starting Saint. John's wort. Low drug levels and return of disease symptoms are the key clues. The effect builds over weeks and can persist 1 to 2 weeks after stopping the supplement. Patients rarely volunteer supplement use, so clinicians must ask directly. When St. John's wort appears in a stem alongside falling drug levels or relapse, CYP3A4 induction is the answer. Question 50. A community health nurse is screening patients in a low-income clinic and identifies a family struggling with food insecurity, eviction notices, and inconsistent employment. According to the Healthy People Framework, which domain of social determinants of health does this family primarily fall under? Your options are A. Economic stability, B. Genetic predisposition to chronic illness, C. Health literacy alone, D. Personal motivation to seek care. Take a second. Which answer would you pick? The correct answer is A. Economic stability. A is correct because the Healthy People Framework groups food insecurity, housing instability, employment, and poverty together under the economic stability domain. This domain captures the financial conditions that shape access to nutrition, shelter, and health overall. B is wrong because genetic predisposition is a biological risk factor, not a domain of social determinants. The framework focuses on environmental and social conditions, not heritable disease risk. C is wrong because health literacy is a component of the healthcare access and quality domain, not economic stability. It addresses the ability to understand and act on health information. D is wrong because personal motivation is an individual psychological factor rather than a structural social determinant. The framework deliberately focuses on conditions in the environment that shape outcomes. Social determinants of health are the conditions in the environment where people are born, live, learn, work, and age, and they powerfully shape health outcomes across entire populations. The Healthy People Framework, developed by the U.S. Department of Health and Human Services, organizes these conditions into 5 distinct domains. The 5 domains are economic stability, education access and quality, healthcare access and quality, neighborhood and built environment, and social and community context. Each captures a distinct cluster of structural conditions that influence health, none of them biological or purely individual. Economic stability is the domain most frequently tested on exams. It captures financial conditions, employment status, food insecurity, housing instability, and poverty that create cascading downstream effects, including chronic stress, poor nutrition, and delayed medical care. On exam questions, match the dominant issue in the patient scenario to the correct domain. Food insecurity, eviction, and unemployment all point to economic stability. Remember, genetic predisposition and personal motivation are distractors. They are not healthy people SDOH domains. When a STEM describes financial hardship, housing instability, or food insecurity, economic stability is your answer. Knowing which structural conditions belong to each domain, not just memorizing the list, is what exam writers are testing.
You have reached the end of our first question set. For the free complete exam preparation, visit our website link in the description, where you find thousands more practice questions and comprehensive study guides. Thanks for studying with us today. See you in the next video.